Okay, let's take a seat. We're going to start our next session. And this session I'm probably most excited about. I think there's a lot of topics here that everyone wants to know about, and we made a formal part to the agenda so that we could talk about essentially patient optimization preoperatively. So the first talk will be given by Corey Walker, and he'll be talking about the challenges of the aging spine, frailty, osteoporosis, and sarcopenia. Oh, shoot, you're moderating.
Thank you so much for having me. I really appreciate it. And this is my first year attending this meeting. It's been really nice. So this is a real honor and something that I'm really kind of passionate about. And I think that is going to set the stage for all the great talks that are to follow. And we're really going to be talking about how do we assess these patients who are getting older and older and older in our clinics and deciding whether they're good surgical candidates or not. Here are my disclosures. So we heard all day yesterday all the amazing talks about things that we do in the operating room that will change the trajectory of our patients' outcomes, tethers, getting the alignment right, spinal pelvic fixation, et cetera. But there's so many things that we don't have control over. And, we had a great talk yesterday about PJK from Mike, and it was just like, you look at all the things that we've implemented and tried to do, we really haven't been able to move the needle a lot. And I think a lot of that is our assessment of these intrinsic patient factors that we don't have control over, or we do have control over, but we're not doing anything with. So one of the things that's come up time and time again and has grown in all of medicine, but particular in our spine literature, is this concept of frailty. And I think it gets thrown a lot around, and so I'm going to kind of discuss this a little bit because I think the idea of frailty is, in our world, your patient's tolerance for this immense trauma that you impose on them doing an operation. But frailty in other categories really is a phenotype and was described early on to describe older patients in nursing homes who were, at risk of death and loss of health span and all these things, and kind of composed of these 5 core elements. And then this guy, Rockwood, who's a gerontologist, described this concept of trying to quantify frailty. And he did something really brilliant. And he figured out that if you could basically count the number of patient health factors, and if you have enough that you take into account, it doesn't really matter what they are, the relative number of those health factors is strongly correlated to a quantifiable amount of frailty. And so this was called the deficit accumulation model. And this really served as the birth of a huge field of frailty indices that therein became super popular across all areas of medicine. And in our own deformity world, Chris Ames and the ISSG, and actually UCSF's own kind of product here was this adult spine deformity frailty index, which used this exact accumulation model concept, but with spine-specific things, as you can see here on the left. And basically, you just count these. There's no weighting to this. It's just you count the number of deficits that the patient has, and this strongly correlated to clinical outcomes that they looked at, which were pertinent to our patients, PJK, reoperation, pseudo, et cetera. And they categorized these patients and showed statistically significant differences. The challenge with this in our clinical practice is who's going to go through every single one of these and put a check mark in your clinic. And a lot of the inputs here are based off of the SRS score. If we don't have that available, or we don't regularly collect it, or a patient do it, then we're at a loss and we can't use this. And moreover, the question is then, what do you do with a number 16 versus an 8? It's all relative, but you don't really, it gives you an idea, but it doesn't give you an actual answer. What we've been working on with some of our computational scientists at Cedars is looking at patients and the data that we have readily available in the EMR. So basically Epic-based data, and seeing if we can just take this stuff that's already there and predict outcomes. And basically establish a frailty index with machine learning, with stuff that we don't have to go take out of a chart and add up ourselves and put together. And we've been able to really look at some pretty reliable outcome adverse event metrics and prove that. And if you really then go back and look, we just did a comparison study. Okay, how do I do some of these hospital-based frailty indices? There are frailty indices that are based on the electronic medical record where you don't need to do this other stuff. How well do they do against typical machine learning? And actually, the answer is they give you some indication, but their predictive value is a lot less in a spine surgery patient. And if you actually decompose the elements of each of these frailty indices and run them through a machine learning algorithm, it does better than if you just use it as a straight frailty index. And it's because all the things that go into these measures, they're not linear variables. They have intrinsic relationships with each other, and machine learning tends to do a better job at predicting that. So I think as we go forward and we look at this concept of frailty, probably what's going to happen is it's going to morph into more of a machine learning predictive analysis based off of algorithms and patient data that's already available, rather than us sitting in a chart, counting deficits. For spine surgeons, we also know that there are direct things in the aging spine that contribute to outcomes and correlate strongly with frailty and back and forth. Specifically, we know that poor bone health and muscle health impact outcomes. Bone health, obviously, for several reasons. It affects the strength of our fixation and our ability to correct. It basically is related to our ability to resist fractures at our junctions. And there's a part that we don't really capture well at all, which is bone physiology and bone healing, which refers to the part that contributes to pseudoarthrosis. And we know some people just don't heal. And things like smoking and nutrition and other things can affect that. And simultaneously, sarcopenia has been studied extensively for two reasons. One, it serves as a surrogate biomarker for frailty. So people grossly look at sarcopenia as a means of assessing patient frailty. But also, as spine surgeons doing these long segment constructs, the muscle tissue envelope around the spine is immensely important because it has to do with our compensation. It has to do with our ability to withstand intolerances and getting the perfect alignment. And so we all know that some patients have perfect alignment post-op and they still fail, right? And so we also know there's patients who we didn't really do that great of a job getting their numbers right, but they're still doing well because they have all the muscle compensation. So studying these things directly is really important. But these disease states are probably very strongly overlapping for several reasons. We know that in large population-based studies that the two coexist, and there's strong relationships between the muscle and the bone from a physiological standpoint. There's endocrine factors that affect both. There are paracrine factors. The muscle actually inserts onto the bone, and there's crosstalk between the two elements. And there's a hallmark of both diseases is fatty infiltration. It's actually something that we quantify when we measure some of these things. And so obesity, which is a huge problem in the United States, probably contributes. And so all of these things come together. And to add insult to injury, there's probably a genetic component to the coexistence of these things. So what I would suggest is that we really start to think about these things in a lumped disease process rather than just purely in isolation. So we talked a little bit about assessing bone health. And here are guidelines from the CNS from a few years ago. And the reality is that we don't really have a lot of guidelines at all. This suggests that we look at vitamin D, DEXA scores, and CT Hounsfield units with a cutoff of 97 in their recommendation. What we do know, and this was brought up yesterday, is if we do get people on anabolic therapies, and this was shown really well with the Columbia group and Zishan and Lanke, that if you do treat people appropriately with anabolic medications, they actually do as well as patients who have absolutely no osteoporosis and better than the patients who have osteopenia that's untreated. So we have effective therapies, but getting people into that area is the challenge. And the reality is that we don't do a really good job of detection with current methods. So Ben Elder is at Mayo Clinic. He's one of the kind of smartest people in the room for this sort of discussion. And they did a really nice study that's not really cited enough, but they looked at the different ways of evaluating bone health, and they actually put together a kind of a linked assessment of bone health to see how well they could predict osteoporosis using FRAX scores, trabecular bone scores, DEXA, CT Helmholtz, et cetera. And actually what they showed was striking is that DEXA only accounted for about 25% of the osteoporosis. So if you use DEXA alone, you're missing 75% of your patients. We measure Hounsfield units. Well, Hounsfield units cover about 37%. So we're missing the boat on a lot of patients. It was brought up yesterday. What do you do about the patients who have osteopenia with a 2.2 T-score of their femoral neck? Like, the stuff they're not going to get paid for. And I think we're going to hear some good talks about treatment of osteoporosis and managing these patients later. So I'm not going to get into it. But the reality is that our current metrics and methods for identifying patients are lacking. Similarly, sarcopenia has been studied extensively. This is borne out in oncology literature and cardiovascular disease. And there's this European working study group that's like the authority on sarcopenia. And they've met a couple of times over the last decade. And their recommendations are that we define sarcopenia based on muscle strength, muscle function, and basically muscle size. And there's different ways of doing this. You can look at strength with things like grip strength. You can look at physical function by how fast they get up out of a chair or do different tests. And then you can quantify muscle and the actual muscle bulk and quality. And so you can do that with things like DEXA. You can measure appendicular skeletal muscle mass index. You can use body water composition with bioelectric impedance analysis. Basically, some people have these in-body machines in their offices to look at water content, which is basically a surrogate marker for body fat percentages, and that can give you an idea of sarcopenia. And then we can do like we do with Hounsfield units and make opportunistic assessments with available imaging that we already have. Obviously, the oncology literature has led this because every one of their patients has CT chest, abdomen, and pelvises, so they can very readily assess visceral fat and fat in the different compartments of the paraspinal muscles, psoas, and typically, this is assessed in the mid-lumbar at L3 or L4, and you can both measure muscle size with cross-sectional areas or volumetric assessment, or you can look at fatty infiltration and use, there's kind of categorical schemes for measuring that, like the Gutalier score, which is a 5 level, kind of qualitative assessment of the fat in the muscle, or you can actually use machine learning things to actually measure this for you. But the reality is in sarcopenia, there is no consensus on what is the best way to measure sarcopenia. There's all these different types of ways to assess it, but no one really knows how to use this clinically because all these different ways of looking at it and different clinical outcomes in every study shows something else. And for our patients specifically, paraspinal muscle fatty infiltration and muscle health doesn't always directly correlate to other global measures of sarcopenia that people are measuring. And this is a great study out of HSS that looked at different types of sarcopenia evaluations. And the muscle ones that we care about for our soft tissue envelope don't always necessarily line up perfectly with what we see in other measures of sarcopenia. So, from our standpoint, every study you see shows that sarcopenia is related to the clinical outcome that they want to look at, and there's some sort of correlation there. But we really don't know how to use or implement this in our clinic yet because there's all these different varying definitions, and we need to do more work to kind of look at specific spine outcomes and figure out what are the best measures that correlate to those outcomes. And that's something that we need to get better at as a field. If we're looking specifically at PJK, which of these measures of sarcopenia is most strongly correlated to the outcome? Which of these measures is most correlated to global outcomes? So there's a lot of work that needs to be done. Now, some steps moving forward in the same way with the machine learning. This was a study by John Shin and the MGH characters that did the metastatic oncology study looking at survival, just like all the other oncology studies, and they were able to show that they were able to not only segment automatically to L3 based on a CT, and then they were also able to simultaneously measure the sarcopenia based on a CT chest, abdomen, pelvis, and then quantify that, and you put that into an algorithm that correlated to survival. So this is a really good step forward. I think this is something that we need to kind of mimic and model. This is a study that was just published last month in Spine. And I think this is another attempt. This is a group out of Asia that looked at posterior lumbar interbody fusion subsidence and predicting that based on sarcopenia and this MRI-based osteoporosis measurement, vertebral bone quality score, which I have my own opinions on, but they were able to put these things together and come up with a predictive outcome that strongly correlated with the presence of subsidence. And then actually they did a really nice thing. They open sourced a calculator that you can use in clinic that might help you predict that. And I think this is kind of a move in the right direction. There's also this concept of radiomics, which is that, we're putting all these manually measured or even machine measured inputs into a data set, but there's probably features of imaging that we already have that may be predictive that we don't even know about. And we can use unsupervised learning and an analysis and study of these things to predict bone quality and sarcopenia and probably correlate to outcomes. And so we need to continue to develop that. But here's an example of doing that for osteoporosis using CT scans and coming up with some ways to use the machine learning itself to figure out what's the important part of the imaging that is actually most indicative. And then you can therein combine that with clinical outcomes to actually even further boost your predictive analysis. So this is where we're going, and it's really exciting. Our involvement with the Scoliosis Research Society, and I know Joe's part of that, and Alekos and others, and Chris. And basically the idea is to highlight where are we going with all this stuff in the future, both from the standpoint of osteosarcopenia, but also biological clocks and assessing tissue markers. And it's really exciting, but we have a long way to go. And we as scientists and surgeons at the same time have to be participatory so that we get the right direction hit here. And so this complex of interplay of all these things needs to be really looked at by us for spine-specific outcomes so that we get the involvement of surgeons who care about the right things, and we're not deriving these things from oncology literature or cardiovascular literature or whatever. So it's an exciting time, but we have a lot of work to do. I think machine learning is going to really help us. And, again, thank you for the opportunity to speak today. It's a real honor to be here, and I'm looking forward to the rest of the talks.
Thanks, Corey. That was awesome. I think we do have a few minutes for questions if anybody wants to jump in.
Great talk. Thanks for sharing. Do you have a problem? Like we have a problem if the DEX is normal, even though all the other parameters, maybe the Hounsfield units are bad and things like that, to try to get care for the patient's bones. Is that a problem for you guys as well?
Yeah, and I don't want to step, because I think there's going to be some discussion about treatment osteoporosis. I don't want to get into too much. I will bring up one thing that might not be brought up is there is a company out of Berkeley that does, it's called On Diagnostics, and they basically, you can send them your CT scan that you already have, and they will apply a finite element analysis to look at stress and fracture resistance. And it's FDA approved, Medicare pays for it in the US, and you can use that as justification if somebody has, you measure their Hounsfield units and you can't really get that to get the medication paid for. You can send this out and then you have another level of verification. I think obviously if you can document the presence of fractures or something, a little subtle end plate thing that you can call and use these things, but it's a challenge. And I think that there's probably a real need and room for us to trial in spine patients, anabolic treatment in osteopenic patients, and they're the people that are cut off. And it's going to be hard, but I think we probably need to get some sort of involvement of some of the pharmaceutical industry to help do that. But I think that'd be something that would really benefit our patients.
Question around evaluating these patients and their neuromuscular component. We've known for years that Parkinson's disease, MS, other neurodegenerative diseases create problems for long constructs. I think frailty and there's a neuromuscular component there with frailty that we don't understand, and that I think is a big problem for the elderly. Where do you think we're going to go with that evaluation for going forward? How are we going to think about that?
I think it's huge, and I think the other thing that was brought up briefly yesterday is myelopathy, right? And a lot of our patients want to look down at their feet, even neuropathy, right? Peripheral neuropathy. And there's got to be some sort of functional assessment of cerebellar function or how people want to look and stand. So I think there's probably a neuromuscular part of that. Absolute Parkinson's is like the classic example. I had a patient the other day who was 8 centimeters off coronally, just purely coronal. We fixed him and he just can't help himself. That's your inertia concept, right? So how do we assess that? And I think that, the talk yesterday about, assessing thoracic flexibility, that may be a part of it. Assessing motion is going to be probably the most important thing. And patients' balance and, some of these ways of looking at patients' movement. And we got to find a way to do that really easily. We can't just put everybody with little, balls on them and watch them in clinic. We got to have a good way to do that, readily available.
I totally agree. I think just as there's, the concept of sarcopenia, which is loss of muscle mass, loss of functional muscle mass, there's another concept of cerebellar degeneration, right, which is occurring as you age. And certain people have more advanced cerebellar degeneration as a part of aging that we don't understand. And I think that, it's interesting, I've been in this for a long time. Seg Munish been in this longer than me, but we listen to these PJK talks, right? And not a lot has changed. I mean, if you came to this course, it's 15 years old now, this course, Alekos? If you came to this course 15 years ago, right, and you sat in the back row and you listened to the talks about PJK, and then you listen today, there's not a lot that's different. So part of it is, I think, is this neuromuscular component that we don't understand at all. The other worry that I have is the field of neurology is in a huge struggle at all of our places, right? You can't get a neurology appointment. In my system, there's 4,000 pending visits for a neurologist, right? And so they have to be our partners in helping us assess this, and that partnership is going to go away just because of lack of access. And so I think it's important for us to understand this. I really want to congratulate you on your point of this talk, which is that we have to own a lot of this. Because we are dealing with aging population. That's where a lot of our adult deformity surgery is.
Rajiv, do you think there's a role for individual departments, orthopedic neurosurgery, to hire their own neurologists, hire their own endocrinologists, so that you have a little bit more focused treatment?
So the multidisciplinary center of the future is exactly what Alekos is talking about, right? So for example, at UCSF, physiatry lives under orthopedics, which is lovely, right? But you could imagine that if you had a bone health person on your team, right? It doesn't actually have to be an endocrinologist. It could be an APP who is advanced knowledge and is working peripherally with an endocrinologist. We tried to do that at Virginia Mason. We were unsuccessful at doing that. The other area is, hospital medicine. I know of groups that do a lot of complex spine that have their own hospitalist that, comes to their conferences, has, input, right? Part of building that multidisciplinary unit, I'm going to talk about that with the IRIS concept, but is, to your point, bringing all these specialists under our umbrella, right? Because as you know, even with peri-op clearance with anesthesia, that anesthesiologist might not know the difference between an L4-5 fusion and an L4 PSO. It's a completely different ball of wax there. So having specific people who understand complex spine surgery, I think, is a very important component.
Maybe one more question. If anybody has any.
Well, I'll throw it out. Is frailty a modifiable variable?
Well, there's a lot of geriatric scientists that are really trying to look at ways that we can change that. I think from a biological clock standpoint and some of these tissue markers. But it's hard. I mean, I think there probably at some point in the next 10 years will be some ideal medical therapy for that. I think even the concept of, boosting people with growth hormone or something to increase their muscle and, pre-treat them with, exercise to boost them. That might be something. I don't really know if, how much, there's some ideas of maybe like doing multifidus stimulation preoperatively and stuff. I don't know if that's going to get us to that level where it's going to probably prevent the PJF, but there's people moving in that direction. In a lot of them are way outside of our world. So I think there's definitely research in that area, but we don't really have a lot right now. And honestly, what do you do with sarcopenia other than using it as a decision of maybe assessing how big of a surgery you should do? And I think that's where a lot of this machine learning stuff will have to go. And Chris often talks about the digital twin. It's one thing to have a predictive model that tells you a number and you got a 16% risk of this or 56%. But the better model would be you have a 15% risk if you do this, but a 2% risk if you do that. And that's where the actual implementation of an intervention into the models is going to have to go. We can't just have a model that gives you a number that you're wondering, should I still do it? Should we take the risk? It's like, no, you should be able to say, well, if we do this, this is what your risk is. And so I think that moving away from just like correlation analysis and stuff in our research, which is always great, you draw these lines between things, but actually looking at, we have all this powerful, machine learning and AI and stuff, like looking at how do we use that to actually test our plan ahead of time to see what the impact of it will be on the outcome. And that's kind of the exciting part, I think, for our field, because we're really close to doing that, but we gotta jump some hurdles to get there.
Yeah, I think Rajiv's point is a really important one as well. As frailty, we're clumping together vastly different diagnoses. What we need to do is very discreetly cluster the subset with neuromuscular problems, the subset with neurodegenerative problems, subset with muscle bone problems, and the treatments and risks will be very different based on those discrete clusters rather than clumping it all together.
Absolutely.
Thanks again for a wonderful talk. And one of my questions was rate of change. I think baked into all of this as a fundamental assumption is how are things changing? What rate are they changing at? We're not allowed to get DEXs once every 2 years, for example. Even CT scans, if they have like dose reduction protocols, I'm not sure that I can trust the Hounsfield units, particularly next to hardware. So I have a real difficult time making a important judgment about how to take care of a patient that may be frail without having that ability. Are there any tips or tricks or thoughts about that portion, or am I kind of looking in a different direction? Thanks.
I think it's a great point. And even we need a good way to assess our anabolic therapies, right? Are they actually helping? At what point? No one knows whether it should be 3 months, 6 months, a year. Is there a way that we can see where the asymptote is and assess people along the way? We just don't have a good way of monitoring chronologically, changes. But that's a huge need. Absolutely. Thank you.
That was awesome. I think there's also perfect lead-in. I think it's setting the stage for what the rest of the talk I'm so excited about. This is really going to highlight the multidisciplinary approach to these patients, and so we're actually moving outside of the surgical world. Real pleasure to introduce Dr. Long, who's going to teach us about osteoporosis.
Oh boy, in 15 minutes, no less. Excuse me. Yeah, so this is a huge topic that I'm going to try to condense down into a 15-minute, but likely a little bit longer than that. Sorry for the future or speakers ahead. Just give you a little background. I'm an endocrinologist. I'm actually the director of the UCSF Bone Health Program, and which is a new program that's created this year. And so my hope is that we'll be able to review some of the options from pharmacological interventions and hopefully encourage you to kind of intervene and hopefully reduce fracture events in the future. I have nothing to disclose. So just real briefly, I'm going to talk just a very brief review on bone remodeling, just to get a context of how these different therapeutics are their roles, and then discuss the diagnosis of osteoporosis, some current guidelines for treatment indications for therapy, and then discuss treatment options. And I am going to review as many as I can. There's quite a number of treatment options, but I don't want to necessarily be preferential towards osteoanabolics. I know there's a lot of push towards that, but I do want to give credits to the foundational medications, which are the bisphosphonates, and they're actually a very significant positive benefit. So real briefly, bone remodeling. So this is an illustration just to give you a sense of the players involved and the processes involved. There's two key players, the osteoclasts and osteoblasts. The osteoclasts are resorbing bone, the osteoblasts are forming new. The osteocytes are embedded in bone, they're mechanosensors, they're detecting mechanical strain, detecting microdamage, and they're going to start a cascade of events to recruit osteoclasts from the precursors within the blood, forming a resorption pit, allowing then osteoblasts to come in and fill in this pit, forming new bone, and new osteocytes are in their presence. So bone remodeling is two processes involved, bone resorption and bone formation. These are coupled, so they're usually balanced. Most of our treatment agents, the bisphosphonates, selective estrogen receptor modulators, calcitonin, estrogens, and denosumab, act primarily on the left side of this equation. So they're addressing bone resorption, reducing bone resorption. This decrease in bone resorption is followed by a decrease in formation. And so these are coupled, and many times the bone mineral density improvements will plateau after a few years of therapy. However, there's an exception with denosumab. Of the contemporary agents, only teriparatide, abaloparatide, and romosozumab, Evenity, act on the right side of the equation where they're stimulating bone formation. However, keep in mind that abaloparatide and teriparatide also will increase bone resorption. The increased bone formation is a result of robust bone remodeling increase. So how do we get to osteoporosis? So there's many factors involved, and essentially there's an uncoupling of resorption and formation. Where resorption is greater than formation, there's various factors that come into play to create the situation. Aging and menopause are the primary drivers, and hypogonadism in males. This increase in resorption and decrease in formation relatively results in bone loss and a decrease in bone quality. And so coupled together, those will eventually lead to fractures. The decrease in bone loss will lead to a decrease in bone density. It's important to keep in mind that that decrease in bone density may also be a function of peak bone mineral accrual that happens during emerging adulthood. And so this is a lifelong process that might have basically manifestations from events much, much, much earlier in the patient's life. The combination of decreased bone quality and decreased bone density will result in an increased fracture risk. And that is also affected by falls. And there's discussions regarding sarcopenia and issues regarding fall risk, and it definitely contributes to fractures. So how do we diagnose osteoporosis? And so classically, how we diagnose osteoporosis using the WHO bone density criteria from DEXA. And so in this figure or a table, it shows those different classifications: normal, osteopenia, and osteoporosis. And that's using the T-scores, which are standard deviation values from a difference from an average peak bone mass of young adult reference standards. So there are some caveats with bone mineral density determination of osteoporosis. The term osteopenia and osteoporosis were initially created as epidemiologic basically definitions in order to compare low bone mineral density across different countries. When they were created to determine fracture risk in women that were postmenopausal, so their application for men and premenopausal women is uncertain, but they are universally used. It's important to keep in mind that osteopenia is actually, in a young adult individual, a normal bone mineral density. And so osteopenia is a very, very confusing term, especially when you're looking at an individual who's less than 50, because in reality, that T-score may be normal for that individual based upon Z-scores that we use in younger individuals. There are also a clinical criteria that we use for defining the diagnosis of osteoporosis, this instant fractures at the hip, spine, or forearm. And there's also this tool that we use, the fracture calculator, FRAX. And we use these thresholds of a major osteoporotic fracture risk greater than 20% or a hip fracture risk greater than 3%. We missed these slides. Okay, so How do we determine when a patient should be on treatment? And so in 2022, the Bone Health and Osteoporosis Foundation created guidelines for when we would consider treatment initiation. And any individual who has had a hip fracture, a vertebral fracture, meets the criteria of increased fracture risk should be on therapy. Osteoporosis bone T-scores also qualify for therapy. Those that have osteopenic T-scores, if there is a coincidental pelvic fracture, forearm or humerus fracture, they would meet criteria for treatment, as well as those fracture risk that's above 3% at the hip or above 20% for major osteoporotic fractures. Keep in mind those thresholds for fracs were defined using analysis that are undoubtedly out of date at this particular time. So when you come to fracs, I know you guys have heard about it and used it. I just want to give you a sense of how we use it as an endocrinologist. This is basically a snapshot from the website for fracs. It shows a 58-year-old woman who's got osteopenia, and it allows you to input clinical factors that come up with a fracture risk for this individual. Her fracture risk is at 9% for a major osteoporotic fracture and 1.3% for hip fracture. This is a snapshot of a similar individual, 58-year-old female who's got the same bone mineral density, but she has a history of past glucocorticoid use and a family history of a hip fracture. And now her fracture risk is much increased, significantly so, such that the major osteoporotic fracture risk is above 20, and she would be a candidate for osteoporosis management because her fracture risk is presumed to be high. Now, there's some caveats with respect to use of the fracs. It is not designed to be used for individuals that are on pharmacologic therapy. You can consider the use of this fracture risk calculator 2 years after bisphosphonate use or a year after other therapeutics. And so important to keep that in mind. There are some other factors that come into play that might be involved in fracture risk. There is a new tool that's been available called Frax Plus that is making some headway in use, but right now the standard is using Frax. It's important to keep in mind the Frax calculator only uses the femoral neck bone mineral density. So here are a list of therapeutic options that are available to us in the United States that are FDA approved for either osteoporosis prevention or for treatment. And so there's a vast list. I can't go through all of them, but I'm going to try to hit the highlights on quite a number of them. These are the list of the anti-resorptive agents, and so these are the results of clinical trials with respect to fracture risk reduction. One thing that's important to appreciate is that the fracture risk reduction is not uniform across all these anti-resorptives. Across spine fracture, non-vertebral fractures, and hip fractures, there's some various fracture reduction. For the sake of time, I'm just going to talk about denosumab, alendronate, and zoledronic acid. And there are in the syllabus some slides discussing estrogen, raloxifene, and calcitonin issues. So when you think about bisphosphonates, these are the formulations that are available. I've underlined the ones that are most commonly used. Alendronate, risedronate, and abandronate are oral forms that are typically used. The IV form of zoledronic acid is the one that's most commonly used with IV infusions every year. So what are the benefits of bisphosphonates? What do they manifest? So there's an increase in bone mineral density that's clearly observed at the spine of about 5 to 8% and at the hip about 3 to 6% after about 3 years of therapy on the clinical trials. It's important to recognize that there's a plateauing of that bone mineral density increase after about 3 years. The studies have shown that there's a reduced incidence of vertebral fractures, about 40 to 70% with bisphosphonates. Alendronate, risedronate, and zoledronic acid have been shown to significantly reduce non-vertebral fractures 25 to 40%, and for hip fracture about 40 to 60%. It's important to keep in mind that abandronate has not shown or did not show significant reduction in those in the non-vertebral fractures or hip fractures. However, in post-hoc analysis, looking at a very high-risk group with T-scores less than -3, it did show a significant reduction in non-vertebral fractures. So a lot of times people are very concerned about bisphosphonates with side effects. Unfortunately, in the public's perception, many of these side effects are much greater than in reality. And so it's important to just kind of be aware of these side effects and of bisphosphonates. The most common are GI side effects, and that's due to just basically local exposure of the esophageal mucosa to these drugs. And that results in most commonly just abdominal pain or dyspepsia. Now, these rates are very low if the medication is taken appropriately. So counseling the patient to take the medication basically with a large glass of water, staying upright for a half hour. There's some other recommendations on how to take the medication to improve absorption, which is taking fasting and to avoid eating or drinking for 30 minutes afterwards. It's uncommon, but patients may manifest generalized achiness and basically joint pains with the medication, but very uncommon. I'm going to briefly address the issues regarding osteonecrosis of the jaw and atypical femur fractures. For those patients that are receiving IV infusions, it's important to counsel that it's very likely that they'll manifest flu-like symptoms for a few days after the infusion. That'll be self-limited, and those flu-like symptoms are expected to be much less significant on subsequent infusions. So osteonecrosis of the jaw, this one scares a lot of patients. It's very uncommon. Now, there are some risk factors that we're mindful of that might put someone at a higher risk for these events happening, namely if they've had cancer therapies, including radiation or chemotherapy or steroids. Poor dental hygiene. We very much encourage patients to have regular dental care in order to avoid invasive procedures, namely tooth extractions. Regular dental work, cavity, fillings, crowns, root canals, that's fine. You're not going to have an issue with ONJ with this medication. The prevalence is very low. I mean, 1 in 10,000 initially when you start on therapy. When you're about 5 years of therapy, maybe it's about 1 in 2,000 may manifest this, and a 10-year mark, it's about 1 in 500. So it's very uncommon. Atypical femur fractures are also very uncommon, and so it's associated with bisphosphonates. The duration of therapy likely increases that rate of these events. The causality is not really clear. We presume it's pretty low turnover, accumulation of microdamage that leads to these fracture events. If we, just to give you a sense of the numbers, if we take 1,000 patients and treat them with bisphosphonates for 5 years, using basically the criteria for treatment and the event rates that we've seen and the fracture reduction, 1,000 patients put on a bisphosphonate for 5 years, you're going to prevent up to 50 non-vertebral fractures, up to 100, 115 vertebral fractures. There might be 1 to 2 atypical femur fracture events. So there is a very low risk of these events, and there's a significant increase in fracture reduction from common osteoporotic fractures. If we look at the denosumab data, there's a estimation of about 280 clinical fractures are prevented for every 1 atypical femur fracture. So that risk is lower with denosumab. So there are some controversies in care. So how long is the optimal therapy for bisphosphonates? We know that the longer you're on therapy, the more likely you will see these events. And this notion of a drug holiday comes into everyone's concerns. It's something that's applied only to bisphosphonates, and you're trying to allow washout of the medication, and you're trying to time the risk of these events that are rare with the benefits of therapy. And so typically we consider IV therapy courses around 3 years, oral therapy courses around 5 years. But if the fracture risk warrants, you can go out to 10 years and you're going to receive, if the fracture risk is really high, you're going to receive significant benefit that you're not worried about these risks. And so it's important to keep in mind these time durations. So switching gears to denosumab. So it's a monoclonal antibody targeting rank ligand, which is an activator of osteoclasts, allowing osteoclast maturation. It's given as an every 6-month subcutaneous injection. In the 3-year trials from the Freedom trial, there's a 9% increase in spine BMD, a 4% increase in hip BMD, and there's a significant fracture reduction at vertebral sites, hip sites, and non-vertebral sites after 3 years of therapy. There's actually an extension trial going on 10 years that showed continued increase in bone mineral density with lower bone turnover and good safety data. This is a figure that shows that 10-year extension. What's striking about this is that you have this continued increase in bone mineral density over 10 years. Bisphosphonates, you're going to see this plateau, but for reasons that aren't necessarily clear on a drug that's targeting osteoclast maturation, there's this continued increase over a 10-year period. So, how do we consider denosumab and the duration of therapy? Is it necessary to stop therapy after a certain year? The 10-year extension trial would suggest that you don't need to. There's safety data that show that it's very effective. And we know that stopping denosumab, though, leads to rapid bone loss and a risk for multiple vertebral fractures. So there is a conundrum with this medication on how long you're going to stay on therapy, whether it's an indefinite therapy or a need to stop. And so just to give you a sense of these concerns, this is a schematic, basically kind of a cartoon illustrating what happens if you discontinue denosumab. So when you're on denosumab, you're going to see a reduction in fracture risk. You're going to see an improvement in bone mineral density and a reduction in bone turnover marker, CTX. When you stop, within 12 to 24 months, there's a rapid increase in bone turnover markers, increased bone resorption markers, loss of bone mineral density, that within a year, you're going to lose the gains from therapy, and your fracture risk is going to significantly increase. And so it's very, very worrisome with this medication on how best to treat and whether whether you can discontinue it. And so there's various different algorithms and approach. This is the most recent one that was published in the Journal of Bone and Mineral Research in 2025. It takes into account the risks of these events with discontinuation. It's really primarily a function of duration of therapy, but as well as whether or not the patient has had fractures beforehand. It's a higher risk, whether or not they have had bisphosphonate treatment in the past, whether or not they've had gains in bone mineral density. The magnitude of the gain, the higher the gain, the bigger the risk of loss. And so this algorithm is there for you to just keep in mind. The standard approach is to give bisphosphonates after you discontinue, but whether it's 1 dose of IV bisphosphonates, 2 doses, 3 doses within a year, it's really uncertain. And so there's a lot of thought and anxiety that goes into this. So just be very mindful of that when considering denosumab, is how long is this patient going to be on therapy, and whether or not you're going to try to get off. And if so, do it early rather than once you're about 5-year mark. I think you're continuing on therapy indefinitely. So I'm gonna switch gears to anabolics. So there's a lot of excitement about antibiotics and what they can do. So we have two that are PTH receptor agonists, teriparatide and abaloparatide, both delivered as daily subcutaneous injections. They have an FDA indication for treatment of men and postmenopausal women with high risk for fractures. So it's important to keep that in mind. There is an FDA indication for that. The BMD effects, we're going to see significant increases. Keep in mind, this is an 18-month treatment window. So bisphosphonates, we're looking at 3-year changes in bone mineral density. Now we've shortened it down to 18 months. So it is a dramatic improvement in bone mineral density at the spine and at the hip. There are some adverse reactions associated with these medications. Namely, there's some orthostasis and there's some kind of abdominal discomfort, some little pains that happen for within a couple hours of the injection that then resolve. We're trying to pulse this hormone through the body, and it's gone within hours. And so a lot of times there's some symptoms associated with that usually do improve with time. Keep in mind, there was a box warning for these medications for increased risk for osteosarcoma. That box warning has been removed, basically about 10 years now for teriparatide and a little shorter for abaloparatide. However, if there's concerns for osteosarcoma, so if a patient has had radiation therapy or has Paget's disease, you want to be cautious in the use of these medications because there might be an increased risk of osteosarcoma. So romosozumab is the other basically anabolic agent, the most recently approved treatment. It is both stimulates bone formation and it does inhibit bone resorption. So it's an inhibitor of a antagonist for Wnt signaling that then leads to this increased bone formation. It's given as every 4-month injections for a year. It also has an indication for individuals with high risk for fractures. Now, keep in mind, it has an indication for postmenopausal women. And so for men that you're considering this therapy, sometimes it can be very problematic in getting this medication approved just because it is approved for women. It has dramatic improvements in bone mineral density. Keep in mind, this is a 12-month period. So this is even a shorter interval showing even greater gains. So it is a very, very potent bone-building medication. It does have a black box warning. It is associated with increased risk for cardiovascular events, strokes, and heart attack. And so it's not indicated for any individual who's had a stroke or heart attack in the last year and those that you feel are at high risk. Now, keep in mind, the first study that was published on this medication, placebo-controlled randomized study, did not show a safety signal for cardiovascular events. The secondary study that was done in comparison between this medication and alendronate showed that signal and prompted the FDA to include this box warning. So is this truly a significant increase in cardiovascular events, or perhaps there's a protective benefit of alendronate, which has been shown, and that's where it basically manifests that signal. So time will tell whether or not this box warning will persist for this medication. So the osteoabolics, when you look at fracture risk reduction, this is a figure that just kind of compares these medications over a period of time. You can't do direct comparisons just because there's different durations. The teriparatide and abaloparatide were 18 months and romosozumab was 12 months. Important to recognize, vertebral fracture risk dramatically reduced significantly across all medications. For non-vertebral fractures, we do see it in teriparatide and abaloparatide. Romosozumab absolutely doesn't have a significant reduction, which may be a reflection of just the number of non-vertebral fracture events in that trial, but it is presumed to reduce those fractures clinically in use. So how do we take all those treatment options and their effects? Fortunately, Felisa Cosman led a group that basically was a combined task force for the ASBMR and the Bone and Health and Osteoporosis Foundation to try to help put all these treatment options into some sort of structure. And they've created this algorithm which basically categorizes patients with respect to fracture risk. And the higher the fracture risk, essentially identifying those individuals that these are the individuals that benefit most from osteoanabolics because they have a high risk of fracture and you want to rapidly reduce that fracture risk. The highlights from this is essentially if you have a T-score that is less than minus 2.8 at the total hip or less than 3 at the lumbar spine, that's considered a high risk for fracture, and osteoembolics are indicated as first-line therapy. If you had a history of a vertebral fracture, pelvic fracture, hip fracture, that's also indicative of a high risk of fracture, and osteoembolics are first-line therapy. So this is a great document, great publication that provides justification for being more aggressive presently, or be more aggressive first off, which is very helpful for our management. Now, sequential therapy comes into play. Keep in mind, if you do a bone building medication, you build up that bone mineral density. If you stop it, you will lose the bone mineral density within a year of treatment. So you need to follow up any anabolic therapy with some sort of antiresorptive to hold on to the bone mineral density. Depending on how much bone mineral density increase you need or fracture resistance you need, you may go from one osteoanabolic to another osteoanabolic in order to continue to stack up that effect. This figure provides kind of what we expect, what happens with these transitions. I think the important thing to keep in mind, if you go from an osteoanabolic to an antiresorptive medication, you will see continued gains in bone mineral density, so that's a good transition. It can be a little problematic when it comes to denosumab and how you're transitioning that medication. We talked about the bisphosphonates and how they can try to protect it. If you go from a denosumab to an osteoanabolic, if you go to a PTH analog, you're likely to lose bone mineral density at the spine. Transiently, it may recover. Hip, you're going to lose bone mineral density. If you go to romosozumab, you may see basically some slight gains at the spine, but you're likely to keep the hip stable just because of that rebound effect. So it's really problematic on that transition from denosumab to other therapies. So in summary, antiresorptive therapies, just so you know, they are safe. They're effective. Don't discount them. They prevent bone loss, they preserve architecture, they improve the quality of bone, they reduce vertebral fracture risk. Most of them, excluding abandonate, basically we know that they're going to improve the non-vertebral fracture rates. Anabolic agents will have a greater effect within a shorter time period. They'll likely have a greater reduction in fracture risk, and they are first-line agents for those individuals at very high risk for fracture. Keep in mind, patient factors will determine the most appropriate drug use. And one thing to keep in mind, bone mineral density change doesn't fully predict reduction of fracture risk. So don't be too fixated on the bone mineral density changes. You can see, you'll see plateauing, but fracture risk still persists with these medications. So just because the bone mineral density is stable doesn't mean the patient did not respond to therapy. The therapies are quite effective, and the bone mineral density may not necessarily reflect that fracture risk reduction. So it's basically a fracture risk, complex interactions, contemporary therapies are very, very effective across all boards. But one thing to keep in mind is no pharmacologic therapy is going to reduce the fracture risk to zero. That's because we can't eliminate trauma and falls. So whirlwind tour, sorry I went a little bit late. I'm happy to take any questions regarding that.
Thank you so much, Dr. Lang. I think we probably do have time for a couple questions.
Thanks. Thanks for sharing useful information there. It was really good for us. Now, we, as spine surgeons, we're worried about fusion as opposed to fracture risk. Like we do have, do these bones like biphosphonates by inhibiting resorption inhibit the bone turnover and limit our ability to get a good fusion? And what would you recommend is like kind of the ideal that would be a good balance that would give us bone to work with, but not inhibit the bone healing? And then is there a time that we should stop these medicines for a while before going through a fusion surgery?
Yeah, that's a great question. One of the challenges is I'm in for the long haul with these patients. So, and a lot of times when they're coming to you, it's the short term. It's like we need to address something clear and present and try to move on. And so I recognize that there's a little bit of a difference in kind of how I see this process and how the folks in the audience may see it. I mean, in an ideal world, we're capturing these patients much sooner before this. They're treated and their bones are much better quality, and the bisphosphonates will provide that improvement in bone quality that hopefully will then improve the surgical outcomes. In my review of the literature, it's really kind of a mix with respect to what is necessarily the best approach. I think any approach is better than nothing with respect to outcomes. I'm not convinced that necessarily bisphosphonates are detrimental and are basically would cause any sort of negative outcome, and that the outcome would be better with bisphosphonates versus nothing alone. And so I think it's a totally reasonable medication option. Now, in the acute setting where we have an untreated individual, and you want to try to get the biggest effect in the shortest time period, I think your osteoanabolics are going to be your best bet. The challenge, a lot of the studies that have been done are retrospective. There's very few randomized controlled studies that necessarily prospectively are trying to capture individuals with a lot of lead-in time to see if we can improve it. A lot of times at the time of surgery, and I feel there's really mixed results on whether or not it's necessarily helpful one versus the other, osteoanabolics versus bisphosphonates. And so I would treat any therapy as likely to be helpful. If we can work towards the osteoanabolics, you're definitely going to shorten that response time, and perhaps if ultimately you're better off on therapy, that's your best bet. But I don't think that bisphosphonates are necessarily detrimental. Does that hopefully answer?
So would you stay on treatment throughout the fusion process?
I don't have any evidence to suggest not doing that. I would ask you to continue on. Now, that said, if the patient has already been on therapy for 3 to 4 years, whether they're on it or off it probably doesn't make a difference, because they're at a point where a medication holiday makes sense, perhaps, where the continued therapy is likely a marginal gain relative to that first few years of therapy. So it has a lot to do with where they're at in their treatment course and whether this is something that's long-term or short-term. Short-term, I would definitely want to continue on to provide that fracture risk reduction. Long-term, there's not necessarily, I think, strong evidence that it's going to be helpful, because that drug is buried in the bone. You've got a huge burden that's going to slowly wash out over time.
Roger, thanks for joining us. And as was introduced, Roger's the director now of our skeletal health service and a really important part of our work. In doing reconstructive spine surgery, what we find is that certainly bone health is a major determinant of mechanical complications. And so our optimization pathways have got increasingly strict. One of our shared frustrations is the difficulty and cost with regard to access, seeing some of especially the anabolics, but even in some cases the bisphosphonates for our patients. So, for example, a patient with a DEXA score of minus 2.4, yet other risk factors, vertebral fractures coexisting. So, to that end, are some of the metrics like trabecular bone score, FRAX, are these things that we can actually use to try and help get authorization? So a FRAX score with a risk of more than 20% of a overall fracture, or I think 3% is the threshold for a spine fracture. Are these things that metrics that we ought to be trying to put into the record to get authorization, or how do you get authorization for anabolics?
Yeah, I would say Frax can be used. It definitely can be used, and I will use it regularly in situations where there's osteopenia on your bone mineral density measurements, which we all know is not necessarily the be-all, end-all when it comes to determining fracture risk. We know that half of individuals that experience osteoporotic fractures have osteopenia, and so it's not great. So Frax is used, and I will use it. What I think is super helpful for us is if there is a fracture history and that referral documenting, yes, it's there, clearly defined, because fracture, as Felicia Cosman's and that position statement basically is clearly illustrated, that if you have this fracture history, that is an indicator of a significant risk for future fracture, and that can be used as justification. So documenting fracture history is very, very, very important, and we use that to primarily drive therapy. And I would say anyone who's got osteoporotic fracture automatically meets the criteria for any therapy. And then the question becomes is, can you massage it to say it's a high risk of fracture and we can get an osteoembolics for the sake of just trying to be as aggressive in the short term?
And then when we put somebody on an anabolic, you acknowledge that the rate of improvement of bone density might be faster than a bisphosphonate. I was impressed by how much improvement there was on bisphosphonates when it's just anti-resorptive. But having said that, how long do we need to have them on the anabolic before we think about a reconstructive surgery? Do we need to wait until there's measurable evidence of improvement of DEXA?
Yeah.
Or is there some time frame that you consider ideal?
Yeah, that's one of the challenges, because with respect to fracture risk reduction and response bone mineral density, yes, it is the most rapid. It'll have the greatest change and the fastest reduction in fracture risk. Now, when it comes to surgical outcomes and how that affects it, I don't know. I really don't. And the longer you can wait on therapy, in my mind, the likely the better the outcome. But obviously, there are other factors that come into play in the decision making and that timing. Your greatest gains are within the first, essentially 6 to 8 months on that therapy. So just be mindful that it's not a linear response. So it's not like we need to go all 18 months to see that gain. You're going to get your most in the first year, and then it starts tapering off. So you can use that to help guide this. Is that at least if you get your 1 year of therapy in, you're going to get probably the biggest improvement in bone density. Now, whether that translates to quality and whether you need more time to improve quality, it's not really clear. But if you can at least get a year, you're going to get the biggest kind of treatment effect from a bone mineral density increase. And with respect to romosozumab, the anabolic window is in the first 6 months. So there are thoughts about cycling that every 6 months. So from Evenity romosozumab, by 6 months, you're going to gain most of your bone mineral density. So that's also mindful as you can consider that. Because that'll be a little bit of a shorter window.
Thank you very much, Dr. Long.
You're welcome.
Really great talk. So next up, in continuing with the theme of multidisciplinary approach, I'd like to introduce Deep Singhal to discuss some of the approaches to the underweight or malnourished patient. Thanks for being here.
Good morning, everybody. Hopefully we're all recovered from last night's festivities or activities, if there were any. Great. Pleasure to be here. I represent Stanford Healthcare and Stanford Medicine. I'm actually a registered dietitian there, inpatient, primarily transitioning into orthopedics as well as spine. Kind of the reason why I chose this opportunity to speak here today was mainly because growing up as a bit of an athlete, played high school and college basketball through my years. And I actually had an L4, L5, L5, S1 herniated disc, which eventually actually led to surgical procedure, went through the healing process. And it was actually something that I thought would have been more relatable to me. So I'm really honored to be here. It's a pleasure to represent Stanford and really hopeful to give you guys hopefully an educational presentation today. No disclosures whatsoever. So I'd like to start with this quote here. First and foremost, Hippocrates did not say, "Let food be thy medicine." That is totally false. Remove that from your brains today. It's not published anywhere. It's actually, what he did say is that, in food, excellent medicine can be found, and in food, bad medicine can be found. And I think that's a great way to kick this off in the sense that this is a reminder that nutrition is not just a objective, but rather a subjective support. And in therapeutics, it's important that in surgical patients, we work through getting a smooth transition, especially after surgery, and reduce the risk of any kind of complications that may arise. So to kick it off, malnutrition is actually one of the modifiable surgical risk factors that we obviously look for. Yet it's often under-recognized in a lot of spine surgery cases, unfortunately. Now, today's approach is really about the underweight spinal patient undergoing that procedure and obviously optimizing the nutrition status for that patient. So what we look at is when underweight, we refer to the BMI of below 18.5. And frequently, these patients typically do present themselves with sarcopenia. And I know we've kind of double-clicked on that several times today, which was actually really insightful. So I do appreciate the conversations around that this morning. Quite a bit of evidence shows that the malnourished patients actually have a higher risk of surgical site infections, the longer length of stay, and of course, even higher mortality or casualty rates. Now, according to most CNS guidelines, we actually look at prealbumin. And, we ask, not necessarily to be or not to be, but to consult or not to consult. And I think that's really relative in the sense that, we see patients who are underweight. We see patients who have a low BMI. We see patients with tons of micronutrient deficiencies. And this will be, of course, subjected to or dependent upon your clinical judgment. And so it's not necessarily always the albumin that we look at, but we look at the prealbumin range, especially if it's less than 20. That actually significantly increases the risk of surgical site infections. So that's a key threshold that I would like to flag for everybody here today. So spine-specific evidence snapshot. Now, in spine literature, there's some support that's saying general surgery and data has shown that low prealbumin does correlate with a higher risk of infections and certain complications, as you all know and see in your respective practice. Now, there's a large database of studies, especially in the New England Journal of Medicine, that does show quite a bit of malnutrition can predict prolonged hospital stay, as well as more reoperations or the opportunity to go back and redo the procedure. Now, vitamin D does play a very important role in that. And as you all know, typically it's still debated. There's still a bit of a kerfuffle around whether or not there's actually some sort of supportive evidence, but some studies do show that faster fusion rates do occur. And I'm sure you can all attest to that with repletion for vitamin D. So from a perioperative screening standpoint, we want this to be fast and feasible. This shouldn't be something that's overly time consuming, but something that you can all use in your day-to-day practices. It should be short and sweet. So we look at certain studies and tools such as the NRS 2002, which is the nutrition risk screening. We look at the malnutrition universal screening tool, or MUST. And then we also look at the patient-generated SG&A, which, if it's available in your facility, certainly is a great tool to use to determine a patient's nutrition status and whether or not they're malnourished. And as about unintentional significant weight loss, some of the things that we look at is if it's over 10% in 6 months, we look at 5% in 30 days, and we also look at 7.5% in about 3 to 6 months as well. Those are some key indications and flags that we will use to maybe consult our interdisciplinary team and refer to the registered dietitian. Some key labs that we look at prealbumin. Of course, that'll be trending over some time. CRP levels. We also look at, we do a CBC, vitamin D and iron studies as well, which could be beneficial. And although we look at the prealbumin that is less than 20, it's also important to be mindful of intake PO. If it's less than 50% of needs, we highly recommend, or at least in clinical studies have shown that it's actually risky to wait. We recommend early feeding as possible, and it can actually increase post-op complications if early feeding is actually not initiated. So we look at some of the things that we can do to optimize before surgery. Now, according to ESPEN, which is the European Society for Clinical Nutrition and Metabolism, guidelines recommend about 7 to 10 days of nutrition therapy for malnourished patients before any major surgery. And even if it means delaying the process, certain days or so. If we have a patient that's severely underweight with several deficiencies in sarcopenia, it's actually indicated to rather wait about 7 to 10 days. Most patients will go about a 5 to 7 day window, at least from what I've seen at Stanford in our clinical practice, but at your discretion, of course. And it's also important to prioritize either the oral or enteral route. For whatever means necessary, if there's no way to eat by mouth, then we look at the enteral access and see what we can do from there. Typically, we combine that with parenteral nutrition only if PO intake and enteral can only meet less than 50% of needs. And a short delay optimized nutrition therapy is actually a much better outcome versus delayed onset. So we look at some of the modern fasting and carbohydrate loading and why that's important today. Modern fasting protocols are somewhat a bit psychological. Typically, as you all know, you'll see clear fluids up to about 2 hours pre-anesthesia, and then solids up until about 6 hours. Now, preoperative carbohydrate drinks, we all know our Ensure Clears that we give to most of our patients. That's actually a great opportunity to drink prior to surgery. Typically, the recommendation there is about 800 milliliters in the night before surgery, and then 400 milliliters 2 hours pre-op. What that does is actually reduces the insulin resistance. That also helps with improving comfort for the patient as well post-op. And on the IDT team, so obviously, we are a multifaceted team, and we have our surgeons, we have our nutritionists, we have our anesthesiologists, we have our nurses. And so this slide mainly is just to highlight just a basic overview of what each discipline should be in charge of. Typically, nutrition optimization is a team effort, so it's not just going to rely solely on the RD. Although we'll write the tube feeds and TPNs, we do rely on a lot of the physicians, we do rely on our nursing team, and we do rely on the anesthesiologists as well to make sure we're implementing the correct practices. What we look at, for instance, with surgeons, they'll trigger the screens, they'll go ahead and approve short delays if and when needed. We look at the anesthesia team, we'll coordinate the fasting and carbohydrate loading with, especially with ERAS protocol. And then we look at dietitians such as us, we calculate the nutritional needs and provisions that'll go into whatever respective feeding or diet order that's typically processed for a patient. And then our nurses and PTs are always very helpful in terms of reducing intake and reinforcing intake and encouraging early mobilization post-op. So let's take a look at an inpatient plan here. Post-op nutrition should really start early and supplements with about day 0 to 1 or enteral feeds within 24 hours if intake is inadequate. And again, when we look at inadequacy, we look at about 50% or less. We also want to maintain glycemic control and pain management as that's going to be supportive in helping a patient eat. We also have that if a patient is meeting less than 50% of their needs by day 3 or 5, you can create an initial bridge of parenteral nutrition subject to clinical team's discretion. And it's always important, something not forget, we should always monitor refeeding syndrome, especially if a patient is malnourished. More oftentimes than not, we see those electrolytes kind of get out of whack once we start introducing nutrition. So some basic optimization orders that we look at for the interdisciplinary team. Practical inpatient order set usually requires the following. It's about 2 to 3 oral nutrition supplements daily and a bedtime snack. If oral intake is below 50%, again, that's where we kind of get into the options of enteral versus parenteral feeding. And then nocturnal if necessary. If we need to do a cyclic feeding, that is an option as well for most patients. We also want to correct any kind of micronutrient deficiencies. That's going to be inclusive of vitamin D. We've got our iron, preferably, if IV, if it's an urgent case. We look at B12 and folate, and then we also look at calcium, and then of course our electrolytes with respect to refeeding. Now, repletion here is not optional. If it directly supports, healing infusion, that is something that we should always take precedent first. So, just some common pitfalls, just for some estimated nutrition needs, what that typically looks like for underweight patients or malnourished patients. It's going to be dependent on the patient case, but what we look at is there should be anywhere from about 25 to 35 kilocalories per kilogram per day, and that's going to be subject to patient's weight. And now protein is going to be the most important for the healing infusion process. So we do look at about 1.2 to 1.5 grams per kilogram. But now if the patient is severely malnourished or underweight, that's when we can kind of up the ante and go to about 2, especially if they're catabolic or in severely depleted states. And of course, we definitely want to monitor our hydration and electrolyte status, especially phosphorus and magnesium during the refeeding time. And just some common pitfalls to avoid and some things that might be common in practice, but shouldn't always be practiced. Common errors include waiting for abnormal labs instead of screening early. I think it's really important for us to, put our panels in, put our orders in, and get those lab results ASAP. And we also don't want to solely rely on albumin. As we know, we look at pre-albumin, given the shorter half-life. That's actually a better indication of nutrition status in comparison to albumin, which could actually be more of an inflammatory response. And we do want to avoid skipping any supplements. That is a very important one as well. Even if intake is adequate, we always recommend providing that just to provide additional K-cal and protein provision. And last but not least, don't let the patients stay in PO longer than necessary. We prefer to, as dietitians, at least at Stanford, and it might be different in UCSF, we prefer early feeding ASAP as soon as possible. So just a typical pathway for an underweight elective case. This pretty much summarizes the pathway we use, and that's going to be a screening protocol. That'll have the NRS 2002. We use the MUST, or we can go ahead and get baseline labs along with our subjective global assessment for patients. And then most importantly, begin 7 to 14 days of optimization in underweight patients. The sooner, the better. I think it's important to set clear protein and calorie targets, correct any anemia or deficiencies, if any. We definitely want to follow the ERAS feeding protocol. And post-op, we obviously monitor intake, we monitor labs, and of course weight. And if we don't see any kind of uplift with just PO, it's okay to bridge with parenteral or enteral nutrition as needed. It's more work for your pharmacist, but hey, we've got to do what we've got to do. So just what a case study would look like here. Here what we have is a real-time example. This was a patient that I actually dealt with a couple weeks back, 65-year-old, got a BMI of 17.8 with a 12% weight loss over the course of 2 months. And there's a low prealbumin. I believe it was about 16, if I remember. Typically what we would do in this situation is you'd probably delay surgery anywhere from 7 to 10 days just for ONS. And then you'd probably include, if not able to meet needs by mouth, some sort of nocturnal feeding enterally, where those protein recommendations will be about 1.5 grams per kilogram, and IV iron for anemia if there's any corrective action needed there. And then with early feeding post-op, of course, you want to avoid the refeeding issues. So any kind of issues there with electrolytes, we would monitor the electrolyte profile for this patient. And then a brief delay pretty much is what saves significant morbidity or risks. So just some key highlights. Underweight and undernourished patients in spine surgery do benefit even from short perioperative optimization. We do want to use simple screening tools. I think it's important to initiate that sooner rather than later. Follow our ERAS principles and protocol. And then most importantly, we want to make sure that we have the interdisciplinary teams support. At the end of the day, this is a team approach, and it's not just going to take one. It really does take all of us. Those are my references for today. I really do appreciate you all. Thank you.
Thanks so much for that great talk. Super practical. We definitely have time for questions.
With the use of modern GLP-1 agonists that's being used significantly right now, there's an anecdotal understanding that these patients are malnutritioned, and I'm wondering if that's true or not, and if we should be undergoing a preoperative optimization with a similar 7 to 14 day nutritional supplementation like you do for the under BMI patient?
That's a great question. The GLP-1, that's become kind of a trend and fad in the past year. And, some patients who are taking that medication, there have been some studies. There is still a bit of debate on it, on whether or not that protocol should be implemented for a patient that's underweight or that's actually using it. The consensus from what we've seen from most studies is yes, you would want to implement and follow the same protocols and steps that I was able to outline today. But again, it's going to be subjective to your clinical judgment. If a patient's coming in and there's additional, complications or issues that we have, you would be more mindful of that. But the short answer on that, the consensus is yes, you would follow the same protocol steps.
Just have a quick follow-up, but for a different type of patient. We've had those patients that are under BMI, that are potentially malnourished. You do think that by doing a 7 to 14 day, even though their BMI may not go above that threshold of 18.5, undergoing a very large surgery, you're still improving your risk of, infections or complications?
Absolutely, especially if there's sarcopenia and suggested muscle breakdown. It is very important to get that nutrition in early. Not only is that going to help the patient from a repletion standpoint, but also from the healing process post-op.
I think for those of us that have taken care of these severe deformity patients, elderly female patients with BMIs in the 16 or 17 range, we've struggled to get their weight up. And so one of the things that I've done over the last 20 years is a PEG tube. And that is obviously, we remove it when we're done with it. But I've seen some success with that. And I know that when our nutritionists changed, they thought that was fairly radical. Thoughts about that? I mean, a lot of these patients don't have an appetite. They're in pain. They've lived, chronically malnourished to begin with. And so, giving them high volume feeds, or high calorie feeds through a PEG tube seems to be, overpowering that. Any thoughts about that?
Yeah, no, Doctor, I appreciate that. You'd be our best friend at Stanford, I'll tell you that. It's not radical. We prefer that. If anything, what we do is we would do a very slow trickle feed, slow approach. Even if it's from a bolus perspective, we start off with maybe 1 to 2 boluses per day, see how the labs react, and then reassess, and then go back and up the ante from there. But typically, no. I think it's a great approach. We see it quite often.
Deep, thank you. Glad my wife was able to recruit you to do this.
Absolute pleasure.
2 questions. One is the pre-op setting in terms of what we should give to the patients. So we have trouble getting the patients to see nutrition.
Yeah.
It's similar to other fields. In neurology, we talked about that. So if we can't have them see a nutritionist, what should we, for that 7 to 10 days of optimization, give to them?
Yeah, I think it's a great question. More oftentimes than not, whether there's short staffing or issues or you can't get an RD or nutritionist involved, the number one thing that we look at is if we can feed by mouth, PO optimization. We throw the supplements on there, primarily those clear drinks, whether it be an Ensure Clear or Boost Breeze, as I'm sure are very common in our hospitals. Those are actually still very good, still get some calorie and protein provision in prior op. I would recommend taking that route. Now, for example, if a patient's not able to eat PO and we're taking either an enteral or parenteral approach, then that's when we can kind of slowly start to introduce the trickle feed process and or a slow TPN infusion would be helpful. Yeah.
Yeah, we're doing this a lot in the outpatient setting. So having those boosts may be the way to go. On the flip side, post-operatively, I commonly get calorie counts and have nutrition weigh in pretty early. At least at UCSF, there is significant resistance to putting feeding tubes in. Yeah. We don't do the PEG tubes, we do feeding. And the main concerns are around cognitive status, altered mental status, et cetera. Can you talk to us a little bit about what is the real risk of these feeding tubes, what the resistance is, and then on the flip side, if you were to send patients out on a feeding tube, is it 2 weeks, 3 weeks? Kind of what do you recommend for duration of feeds?
Yeah, I think if we're using an NG tube, 18 French is going down, and I think the number one thing that you look at if a patient is maybe experiencing dementia or having some sort of agitation or issues, we always run the risk of pulling that thing out, and then we've got to call IR, do it back in again, and put it back in, right? And then you get a KUB. It's expensive, but it happens for some patients, and it's very common. I've seen it. We've got a patient last week. She pulls it out, I think, like over 8 or 9 times in a week. We've gotten to the point where we're like, hey, we're going to put the PEG in. Let's go that route. But I think you bring up a good point. If there are some altered mental status involved and a patient's unable to comprehend what's going on or be able to accept the fact that they're on this tube, you run that risk very highly. And I think your follow-up question to that was the timeline that you're referring with feeding. Typically, I prefer anywhere from about 2 weeks. I think 2 weeks is a very stable time. That gives the patient an opportunity to kind of replete themselves quite a bit. And in the event that PO, if it's still low, then I've seen cases where we've gone up to 3.5, 4 weeks. It's been pretty significant. Actually, at Stanford, I've seen quite a few patients that have run that month-long duration of feeds. Yeah.
Thanks, Deep. This was great. I think my question is there any, on the surgical side and the invasiveness side of it, is there any either threshold or different way you think about preoperatively optimizing these patients if we're doing a minimally invasive surgery that's already, we know is going to have a very low infection rate, very low wound healing rate? Is there invasiveness threshold with the surgery where you're like, oh my gosh, we have to take that 7 to 10 days. Oh, you're just going to do like a MIS, TLIF, maybe we don't have to worry about that so much.
No, that's also a great question. I think the severity of the procedure or the complexity of the procedure does play a key role. As you mentioned, if it's an MIS, TLIF, or ALIF, or whatever it could be that, you wouldn't necessarily have to take the extremes with, making sure that this patient is eating over 50% in the beginning. That kind of surgery and procedure is a little bit more minimally invasive, I would say, or not as extreme. That's when I would kind of maybe scale back from the protocol and not follow the 7 to 10 days. But in the event that you have a major surgery, that's when I would refer back to this. Yeah, that's a great point.
Super helpful. Steve?
Yeah, hi. Thanks for all the insights. It's really interesting for us. We have a lot of metastatic patients that come in and they need surgery urgently, and some of them are actually not all that fit. What is a good strategy kind of post-op on managing these kind of patients? We have to take them to the OR right away. We don't have time really to optimize, and we do, obviously, they're at high risk for complications, and especially wounds.
Absolutely. I think from the inpatient perspective, with what we discussed today, that's going to be kind of our first line of defense, especially if they're coming into the hospital. Post-op, that's when we start to look at, hey, what kind of outpatient resources do we have? Outpatient does, at least at Stanford, I'm sure UCSF does the same, is they do follow the patient extensively outpatient. There are typically what happens, there's a 1 month post-op from at least our protocol, 1 month post-op appointment, then there's a monthly follow-up thereafter. Now, let's say we get those patients who are 60, 70, extremely underweight, 16.5 BMI. Those patients will probably get followed a little bit more frequently. I'd say probably on a bi-monthly basis. But from an outpatient perspective, we would really rely on that until the event that they would come back into the hospital. God forbid they don't have to, but yeah.
Awesome. That was great. Another really, really practically relevant talk. So thank you very much.
Thank you all. Appreciate it.
At this stage, we're going to go to the opposite end of the spectrum. So it's really a pleasure to introduce Dr. Diana Thiar, who's going to be talking about the overweight patient and how do we optimize that patient for surgery. Thank you.
Hi, everyone. It's a pleasure to be here today. I'm a general internist and obesity medicine specialist. I run the medical weight management program at UCSF as well as our obesity medicine fellowship. Here are my disclosures. In terms of objectives, in this brief overview of how to treat obesity, which is a huge topic, I want you all to walk away with a really high-level understanding of how we think about treating obesity with different pillars. I hope you can walk away knowing the 6 FDA-approved anti-obesity medications for long-term use, understand these GLPs, which are not a trend or a fad, but really paradigm-shifting how we can care for people with obesity in the long run. And then understand the role of these GLP drugs in not just treating obesity, but the comorbidities associated with excess body weight. So I always start these talks with understanding what is our goal. When we think about treating obesity, our goal as medical professionals is not to hope that everyone looks the same. This is a room of very fit people, and I suspect, in your field, most people do look a certain way. But when we think about treating obesity, we want to help prevent morbidity and mortality associated with that adiposity. We don't want people to think they have to look a certain way to be valued in society or to be cared for by us as medical professionals. The other thing is that we shouldn't always assume that just because someone has excess body weight that they are unhealthy, but we do want them to understand the risks of long-term adiposity for health comorbidities. We also know that modest amount of weight loss can improve health. With 5 to 10% body weight loss, we start to see clinically meaningful changes in things like prediabetes and hypertension. And it's really above that 15% body weight loss mark that we start to see remission of some of those cardiometabolic diseases like diabetes, cardiovascular mortality, as well as HFpEF. While BMI targets drive a lot of what we do in medicine, we don't necessarily want to fixate on this idea of a normal body weight because we know that it's really percentage change in someone's starting weight that can improve their health risks. It's not taking someone with class 3 obesity and getting them to an overweight BMI. It's trying to get someone that 15, 20% body weight loss to help them have a longer, healthier, more robust life. The other really important thing to note is as we think about treating obesity, we have to think about it with the perspective of any chronic disease management. If we take away the intervention that's treating our patient, that chronic disease will come back. It's the same case with obesity. When it comes to spinal surgical risks, we do want to try and optimize BMI and weight if possible. We know that there are higher risk of postoperative morbidity with a BMI over 30. And with anterior lumbar interbody fusion, the risk is really at that BMI over 31. And what are those risks? You all know this better than me, but it's things like surgical site infection, postoperative VTE, ileus, and UTIs. But on the other side of the coin, we also know that people have really improved functional outcomes post-op at any BMI. So we want to use our clinical decision-making and not be too rigorous and restrictive around the BMI cutoffs as we're thinking about how to treat our patients. Historically, as we've thought about treating obesity, we've thought of it as this pyramid. At the base of the pyramid, we have our primary care providers who should really be treating people with lower BMIs in that overweight category. As BMI increases and risks of comorbidities associated with excess body weight also increase, we have obesity medicine specialists like myself. At UCSF, we have a comprehensive care team of dietitians, physicians, nurse practitioners, behavioralists, and we focus a lot on the pillars of treatment, lifestyle change, which is diet, exercise, as well as anti-obesity medications. At the top of the treatment pyramid is surgery, but you have to remember that just because we have this escalated approach and options for our patients, we have to really follow what they want for their treatment protocol. Just because we have powerful medications or we have surgeries that work, it's really important to provide patient-centered care and patient-centered decision-making so the patient feels respected in whatever they decide to do. The other really key thing is that taking a medication will help people lose weight, but it's not going to teach people how to eat healthier or move their bodies more. So lifestyle change really matters. We want to make sure our patients are eating enough protein. It's a really big focus right now. I mean, at Starbucks, you can get a protein foam. But the reality is in the US, the average American meets their protein requirements, and it's the fibrous foods, vegetables and fruit that are lacking. So as we're counseling our patients to up their protein, move their bodies more, you also want to make sure they're actually getting the micronutrients through proper vegetable and fruit intake. There are currently 6 FDA-approved medications for long-term use in obesity management. The first 4 are sort of the older class of medications, and the last 2 are the newer generation of meds that we use. So we have orlistat, which is a lipase inhibitor. It's not very effective at only 3% body weight loss. The next is Contrave, which is a combination of bupropion and naltrexone, which is an oral pill, and you can see 5 to 8% body weight loss at 1 year, but there is some weight regain at year 2. The third is Saxenda, which was the first injectable GLP medication FDA approved for obesity management, and this was in 2013. 5 to 10% body weight loss at year 1 with maintenance of only 6% at year 2. Qsymia is an oral combination of phentermine and topiramate with 9 to 14% at 1 year, but again, some weight regain at 2 years. And then 5 and 6, what you can see is different, is with semaglutide 2.4, we have maintenance of that 12.5% at 2 years. And then with Zepbound, which is tirzepatide, we actually see more weight loss at the 88-week mark. Why does that matter? Maintaining weight loss is how we actually can improve morbidity and mortality. So numbers 1 through 4 have a certain amount of weight regain, which suggests in the long run, our patients are not going to have reduction in cardiovascular disease, sleep apnea, and things like that. But it's really this newer class of medications that everyone's hearing a lot about that are helping people lose weight, keep it off so that they don't have things like heart attacks, strokes, progression to diabetes, and so on. So why are these medications so powerful? It's because they act both centrally and peripherally. So we as humans evolved to have our hunger and satiety signals regulated in the hypothalamus, a very complex set of feedback loops between the gut hormones and the brain. But we all know that we eat now for reasons that have nothing to do with our energy homeostasis. So historically, medications only worked in the brain. Things like topiramate, bupropion, naltrexone, phentermine, they act in the brain to reduce those hunger noises, increase dopamine, and reduce cravings. But our brain is very powerful and can do things that outperform what is happening there. So people feel the effect for a couple of months, and then they go back to their favorite restaurant or watching their TV show with their partner or whatever, and those food signals start to come back. But what GLPs do is they do continue to act centrally on that POMC cart mechanism to promote satiety, but they also act peripherally. So they act in the stomach to decrease gastric emptying. They act on the pancreas to increase insulin secretion, which is why these are so powerful for people with diabetes. And they also act via the liver to improve insulin sensitivity. GIP has an added benefit of increasing lipolysis and fatty acid synthesis. So it's important to note that semaglutide is a GLP monoagonist, and then tirzepatide is a novel dual GLP-1 GIP agonist, and it is way more GIP agonizing than GLP agonizing. So it's only about 1/8 the GLP receptor agonizing as something like semaglutide. So while they are similar medications, we can't just call them the same thing. It's not like two statins. They're not interchangeable in that way. The side effects coincide very closely with the mechanism of action. So nausea is very common, especially at the beginning and with dose up titration. It's really important to note that being so nauseous that you can't eat or throwing up so regularly that you are having signs of malnutrition, that's not normal. Our goal is to promote a healthful lifestyle. So if someone is so sick that they're not able to go to their kid's soccer game or get out of bed and go for a walk, this is probably not the right medication or not the right dose for that person. The other common side effects are on the opposite end of the GI system, things like diarrhea and constipation. Those are managed very well with added fiber supplements, even in your patients who are taking in a lot of dietary fiber. Adding in a daily supplement can help. We also sometimes see things like fatigue, headaches, oftentimes associated with low PO intake or dehydration. And the rare but serious side effects are things like pancreatitis and cholecystitis, seen in less than 1% of the study population. Suicidal ideation was not seen in the RCTs, but in the post hoc FDA reporting, some people have reported it. It has not panned out in looking at the secondary studies, but we still bring it up with our patients just to make sure they're aware that mood changes can occur. There are two absolute contraindications to use. One is personal or family history of medullary thyroid cancer, or MEN type 2. This contraindication has given the entire class of medications a black box warning, but it's important to note that these effects were seen on rat thyroid studies, and the rat thyroid is not a good human surrogate. So we haven't really seen it pan out, but we're also very vigilant about screening for these personal or family histories before initiating drug. The other thing is that this class of medication is contraindicated for use in pregnancy. It is not a teratogen, but it does increase fetal loss through placental disruption. So it's important for our patients who are trying to get pregnant, actively trying to get pregnant, to understand their risk and come off the medication before trying to conceive. I think the other side of the coin is that we've actually seen increased fertility rates and accidental pregnancies in women on these medications, because with weight loss, we see more better reproductive ability. So as we counsel our patients, we tell them of the risks, but also sort of the reality that it's still possible. In terms of the results, we talked about what it looks like at 1 year, but what's really key to note is that for both classes of medications, there are hyperresponders. So for semaglutide 2.4, about a third of patients had over 20% body weight loss. And for tirzepatide, over a third of patients had more than 25% body weight loss. That's the low end of a sleeve gastrectomy. So something like tirzepatide in these hyper-responders could be a quite powerful medication that's nearing what we can see with surgical interventions. And how are these medications used? They are single-dose pens that are weekly injectables. You can up-titrate in 5 months, but you don't have to. So if a patient is having a lot of side effects, you can spread out the timing between injections or wait 2 months, 3 months before up-titrating to make sure they feel better before you go up on a dose. So how do you think about this? If you have a patient who's about 250 pounds, 5'11", that puts them at a BMI of 35, which is class 2 obesity. To get below that BMI of 30 to decrease those surgical risks, that patient would need to lose about 14.5% of their body weight. That's higher than what we would expect with something like semaglutide 2.4 for the average person, but it's definitely within range for something like tirzepatide. Now, what is the time course of this weight loss? If your patient needs a surgery, but they have to lose weight beforehand, unfortunately, it is a quite long duration. So we see max weight loss around 68 weeks for something like semaglutide and closer to the 88 weeks mark for tirzepatide. So this is something that requires planning. If your patient urgently needs a procedure, bariatric surgery will be a quicker way to get weight loss. We see those rates of weight loss really peak around 6 to 12 months for surgery. So that's an important thing to remember. The other thing is that we know when these medications are taken away, people regain their body weight back. So both with the STEP 1 extension trial and SURMOUNT-4, both studies had slightly different designs, but when patients were removed from drug, maintained on lifestyle change, they regained 2/3 of their body weight back. Now that matters both clinically because you're taking away all those potential benefits, but the reality is that the person's body composition has also changed. When we lose weight, we lose fat and a little bit of muscle, and that's okay. But when we gain weight, it's our adipose reserve that grows. So when that patient gains 2/3 of their body weight back, that's all in their adipose tissue. And so now their body composition profile has changed to be more fat and less muscle than before they had initiated therapy. And that's what's key. We know that women are likely to be in that hyperresponder group, specifically for tirzepatide. So with the tirzepatide SURMOUNT-1 through 4 trials, they did sex-specific weight loss trends. And what you can see is that women were on average losing closer to that 24, 26% body weight loss, where men were lower, closer to the 15 to 20%. And when you further subcategorize this based on hormonal status, it's really premenopausal women that are losing the most amount of weight, and they're losing a lot of visceral adiposity. So premenopausal women are having really profound metabolic changes with this medication. It's also important to know that they could be hyperresponders and overshoot the mark. So you want to make sure you're treating your patients very carefully with these medications so they don't lose too much weight and become malnourished, as you had mentioned. I'll be very brief. You have these slides in case you want to unpack the data here more. But my goal as an obesity medicine provider is not to treat someone because of the way they look or just to help them lose weight. It's because we know that treating obesity can treat all of these other cardiometabolic and mechanical diseases. So by treating this one condition, we can really knock out all of these other things that really reduce people's quality of life and their lifespan. There are really 3 main trials that you all should know about that have shown reduction in morbidity and mortality and have gotten secondary FDA approval for these class of medications. The first is the SELECT trial. It was the first trial showing a medical intervention for obesity that can reduce MACE risk. So this was a very large study, 17,000 participants with a BMI over 27 and known ASCVD defined as MI, stroke, or PAD. Why does that matter? Because the FDA shows really high fidelity to study design for obesity. And so the patient has to have MI, stroke, or PAD as their ASCVD diagnosis, not just an elevated ASCVD risk, hyperlipidemia, hypertension. None of that works. It's very clearly these 3 indications. This was about a 4.5-year study. People lost about 8.9% body weight at that 5-year mark. And what you can see in box A is that there was a 20% risk reduction in the primary composite endpoint, which was the combination of time to first MI, stroke, or death from any cardiovascular cause. Metformin for diabetes has about a 20% MACE reduction. So this is a really profound finding. For tirzepatide, they're doing the trials right now. We're hoping to see that data come out in early 2028. Unfortunately, there's not just a class effect FDA approval for this cardiovascular outcome. So they're going to have to study this for every medication that comes out. The other big trial in the space is SURMOUNT-OSA, which is looking at tirzepatide for OSA. And in this patient population, it's people with a BMI over 30 and moderate to severe OSA, defined as an AHI greater than or equal to 15. Again, a large trial. And over the course of the year, people lost around 18% of their body weight and had a profound reduction in their AHI by about 50%. And almost everybody in that moderate sleep apnea group went to either no sleep apnea or mild, and even in the severe group, over half the patient population regressed to the mild or no sleep apnea. And it's this SURMOUNT-OSA trial that got tirzepatide's secondary indication for use in obesity plus moderate to severe sleep apnea. Again, very strict with that definition of BMI and AHI cutoff. And then the third is the study in MASH with semaglutide 2.4. It's the ESSENCE trial. It was a very long study, 240 weeks. It's ongoing, but they published their 72-week data because it was so powerful. It showed pretty significant improvement in steatohepatitis with no worsening of fibrosis, and also reduction in fibrosis with no worsening of steatohepatitis. This got FDA approval in August for semaglutide 2.4 with MASH in the absence of a BMI cutoff. So that's pretty important because it isn't necessarily just related to obesity. Any of our patients with MASH can now get semaglutide 2.4. The insurance companies are still requiring a lifestyle change component, and they are requiring a specialist be involved in the care. So there is a lot of gatekeeping around these medications that is frustrating and really limits our ability to care for all of our patients appropriately. There are other trials that have been done looking at NEOA that have shown improvement, but no FDA indication for that. And then there are tons of other things being studied, and I'm sure you all see this in the news or on social media or hear it from your friends, family, anybody, but they are looking at these medications with substance use disorder, and they have been very powerful in animal models. We're seeing more data come out in dementia, Alzheimer's disease, and Parkinson's disease for these medications in diabetes, and they are now doing prospective studies for obesity. We're also looking at these medications for autoimmune disease like psoriasis, RA, IBD, and then a lot of the reproductive hormone diseases like breast cancer, HS, and then also separately in the cardiovascular space, we are looking at these for AFib. And then as a San Francisco person, I call this space the gold rush because there are tons and tons of medications that are being studied and will likely come on board in the next 10 years. What we will probably see in the next year are the oral GLPs. I'm sure you all saw the news about Orpho getting fast track approval, and then we have high-dose semaglutide as well. There are other dual agonists that are being studied, things like GLP amylin and GLP glucagon. There's a very powerful triple receptor agonist called retatrutide that's completing phase 3 trial. And then we have completely other mechanisms of action with activin receptor inhibitors that are looking at promoting muscle growth. So this is a very rapidly evolving space. It'll give me a job for the next 10 to 20 years, but it's really important for everybody in the medical community to be aware of how powerful these are, how well they work for the right patient, because it's probably the most popular thing in medicine right now, and everybody's going to be asked about it. And with that, I'll leave time for questions.
Thank you, that's very simple. Question about, there's not necessarily a lot size with respect to songs for patients. But is there like a 1-2 punch in terms of, elective surgery with room environment, gastric sleep, and then you couple that with GLP-1, for example? Is there one procedure that you prefer or that you see more success in?
Because of all of the supply chain issues when these medications came out, there have been massive delays in these secondary studies. So the question is, should surgery or a procedure happen first or the medication first? And I think you can probably expect that the internists say medication first and the surgeons say surgery first. But then there's also this third procedural group, which is endoscopic. So I think, an endoscopic sleeve with a medication for your patient who has class 3 obesity, but still 40 to 50 is probably a reasonable approach if you need an intervention quickly. But if someone has a BMI over 60, I do think that bariatric surgery is probably the better first line. Some people are not having the same response, and we wonder if there is so much adiposity that there's not the correct bioavailability of the drug. But you really have to go with what the patient wants. And everyone has a weight story. If you're thin, if you're not thin. And so this is one space where it's important to tell your patients all of the pros and cons and say what you personally would do if they ask. But at the end of the day, you have to go off what your patient wants because everybody has a story.
Do you have a knowledge of what percentage of bariatric surgery cases, like how much they've gone down, let's say in the last 5 years, and do you think there will be any bariatric surgery left 5 years from now?
There's no data that I'm aware of. I don't think they would want to publish that, but the BMI criteria did go down in 2021 at the same time that Wegovy was FDA approved. So there's clear signs that the higher cutoff wasn't going to be enough of an output. In the Bay Area, I don't know how many people are Bay Area people, but bariatric surgery is not super common, but in other parts of the country, it still is. And a lot of medical weight management is housed within bariatric surgery. So I think there's definitely a home for it. I personally think that the laparoscopic procedures will potentially gain in popularity if academic centers, gastroenterologists are able to build up that practice because they just have fewer side effects and less sort of long-term issue with malabsorption. So the malabsorption after bariatric surgery is the problem. And the problem is not that we don't know how to treat it. It's that patients stop taking their multivitamins. They graduate to their PCP, they move to a different state, and people just totally stop tracking all of those deficiencies.
Thank you for your enlightening lecture. I think this is really refreshing. It's a paradigm shift from where we were 10 years ago. And it's great news. I'm just thinking long term. You mentioned that if they come off, they gain 2/3 of the weight back, and it's not healthy because it's mostly adipose tissue, not the muscle is the hardest thing to build. And we talked a lot about frailty today. So can you give me an idea what happens to these patients long term? They just are on maintenance drugs forever, or I have no idea. So can you enlighten us on that?
It's a tricky question. Some real-world data is showing that with intensive lifestyle intervention, people can maintain the weight loss, but the question is for how long? When we look at other data that we have from previous medications, there is a subset of patients who can keep their weight off. And what we know from sort of correlational studies is that really high levels of activity and doing ongoing monitoring of your food intake is what's going to keep you most likely to only regain less than 5% of your weight back. We live in a healthcare system where insurance changes a lot, both what they decide to cover, but also each individual's insurance plans when they switch jobs. So people can't stay on these drugs indefinitely in the current ecosystem. And so what we try and do is say, let's go down the way we went up. If your hunger noises increase, if you start gaining a lot of weight, we either need to put you on a different class of medication, or maybe you should do something like surgery. But we follow those patients really closely. And when they start to gain 5-10 pounds, they know to come back to us. That is not realistic in the primary care population, though. So I think there has to be a bigger shift around how health systems can provide this wraparound care for people who have obesity.
What's the idea around this hypothalamus reset that I read about? And again, I'm not even 10% as smart as you. So I read that that a lot of this is resetting the hypothalamus. So is it that once the hypothalamus doesn't see the drug, it goes back to where it was?
So people who have chronic obesity, the thought is there's a couple things going on. One is that there's a hypothalamic dysregulation. The other is that we know through both fMRI studies and other MRI imaging that there's a different response to dopamine in the brain. We don't know if it's less of a dopamine release or if it's decreased dopamine response in the brain, but it's a combination of both. And so with the medications, we do see some improvement in that hypothalamic response because the GLP receptors are being activated more. But I just was at Obesity Week this week, and what we saw in the fMRI studies is that even with that weight loss, there isn't an improvement in dopamine response, at least in the short term. We don't know years 5, 10 are people who lose weight, do they have that improved dopamine regulation? But it's really disheartening to see that that doesn't happen. And that food noise is what is really troubling for people when they lose weight, and that's why it's so hard to maintain it. So if you come off the medication and you lose that hypothalamic benefit and your dopamine response system hasn't changed, you're really just going right back to where you were when you weren't on the medication. That being said, people who don't have chronic obesity, so think about that person who gained a lot of weight during the pandemic, they might not need such a long-term intervention, and they might also benefit from trying some of the earlier class of medications first.
Just with regard to bone health, this ties in importantly. One of the patients that I treated, a young male in his 40s who had a gastric bypass about 10 years earlier, and you talked about supplementary vitamins and things. He had not been taking that and had perhaps one of the most severe cases of osteoporosis that I've seen. How do you monitor that over time? I've seen two people with bypasses, one with a copper deficiency that resulted in neuropathy, and one with pretty severe osteoporosis.
It's really unfortunate because what bariatric surgery does a great job following their patients, but you all understand that there's a maximum amount of time that it makes sense for a patient to stay with you. Very few PCPs in my own practice, which is a high functioning academic practice, know how to do the labs. And the other thing is patients, they don't even tell their doctors. I just got a transfer patient. I do primary care as well. She never mentioned to me she had bariatric surgery, but I knew because that's my job. But the fact that the patients don't tell their doctors, the doctors don't know what to check, it leads to these really intense complications. And I also think, this is anecdotal, younger patients are not as good about staying on medications in the long run, whereas an older patient who already has some chronic disease and is used to taking a medication, they do it regardless of if they feel any different. And so that's really the tough part about having a young person have a surgery that requires labs twice a year, multivitamins for their entire life, and making sure that they're really staying connected in the healthcare system and also advocating for themselves.
All right. Well, thank you again. That was really amazing. We appreciate you. So we're going to transition now from the preoperative stage to the more perioperative, intraoperative, postoperative phase. And it's really a pleasure to introduce my friend Raj Sethi talking about his enhanced recovery protocol for complex surgery at Virginia Mason. Raj.
All right. Thank you very much. It's a pleasure to be here. I've been in this meeting, I think, for at least 10 or 11 straight years. So it's a great honor to be here. And this is an area that I'm very interested in. First off, I want to really highlight two people, one of whom is sitting in the room, Kellen Nold. Kellen, raise your hand so everybody knows who you are. And Takeshi Fuji. I've had a number of fellows, research fellows from Keio University in Tokyo who have come and worked with me. And Takeshi just completed a year, and this is one of his highlights. This is the topic of this lecture, so that always helps. So here's what I'd ask you to think about. You've heard some really great lectures thus far on what our conundrums are. This is a 75-year-old retired physician. He has a non-fatal disease, but he's severely disabled. He's had a couple of in situ fusions. He's profoundly malaligned, and he undergoes this major operation. And let's not talk about the carpentry here. Let's just think about how are we going to get this patient through this operation with fewer complications. And that's really what ERAS is all about. I've spent the better part of my career talking about this problem of quality, safety, and value in adult deformity surgery, and particularly how do you optimize these patients who have all of these problems that you've heard about this morning, and then how do you put all of these disciplines together to deliver a better product. And the product for us is a sustainable operation as the one I just showed you with few complications. Now, health economics is another major area of interest for me. I went back later in my career and got a PhD in health economics because I was looking at these problems, which is that we spend a lot of money in the United States on healthcare, $86 billion on spine care alone, and that spinal fusion accounts for 7.1% of the costs for hospital stays of any inpatient procedure. So this is a major issue for us to discuss. There's a couple of organizations that I'd like to highlight that I've worked with now for the last 20 years, and one is the SRS. I was the inaugural chair of the Safety and Value Committee a long time ago now, and this was our charge that year to put this together to give people essentially a menu of what they could do in their practices and in their organizations to optimize outcomes. And there's a lot of ERAS principles in this area. The other two organizations that I'll mention here, number one is the Spine Safety Foundation called S3P. I ran the adult side. I continue to run the adult side, and Mike Vitale runs the pediatric side. We do a meeting in New York every year. And a lot of these principles are front and center there. The third one is the National Spine Health Foundation, which is now doing a very patient-centered approach to all of this and what do patients need to learn, right? If we go back to the S3P meeting, the Spine Safety Summit, this is a pretty amazing guy. His name is Stanley McChrystal, and he led the raid on Osama bin Laden in Pakistan in 2012 or 2011. And he really talks about the importance of teams. And I think that teams are going to be very key for us to optimize patients. I think Dr. Walker's talk from earlier about where AI is going to take us and risk stratification is very important to think about too. But we don't really have those tools today, and we need a lot of work to get there. So today, what you can do is you can build these teams because these teams combat stress in many arenas. And if clinicians argue the value of this approach, they argue that multidisciplinary teams are resource intensive, they erode independence. That's kind of yestercare thinking. Really, the future is we need teams, and we deserve a significant effort to standardize care for these patients because we haven't even seen the start yet of how inundated we're going to be with patients demanding these procedures in an era of unsustainable healthcare costs. This work was led by one of my former fellows, Vijay Yanamadala. This is essentially a systematic review of multidisciplinary approaches. You can look at that if you're interested. Doug Burton and I led this work at the ISSG, I think almost a decade ago, also about what factors are modifiable and what factors are not. I will tell you that regardless of anything we say, surgery remains the only option for most of these patients. So we've got to do something better. We talked about this a while ago at Virginia Mason about this spine team approach. I think many of you are aware of this. It's written about also in JBJS reviews. You can look at that in further detail. The whole idea about conferences was how do you standardize care and how do you move the whole lot towards improvement as you see in this a lot here. A lot of these criteria that are being optimized are things you've heard about today. And how do you do that if you're a lone surgeon without a team and you're just trying to do it by yourself in your clinic? It's impossible. You're not doing it. If you think you're doing it, you're probably not doing it, right? So you have to put a team around this and more importantly, a process. I'm really waiting for the day that the computer is going to tell me what to do, right? I think there will be a future for that. Risk stratification in that way is going to be the future, and it's going to be hopefully a lot more foolproof. But right now, optimization is really team-based. So back to what Takeshi did. The reason that we did this was I was asked by one of the SRS committees a couple of years ago to if we had looked into this, and we said, well, is there really any evidence that ERAS protocols help in adult spinal deformity patients? And we said we need to do this meta-analysis and a systematic review, and Takeshi took it on, right? And so the idea is all of the same things, right? We want to reduce risk, and we want to put a pathway in process to reduce risk. So obviously, these protocols have been shown in certain areas, as you can see at these bottom two highlighted papers, with opioid use, 90-day readmission rates being the two major areas, right? However, what we found is that there was a lot of variability in different institutions as to how these ERAS protocols were being put into place. And so that's why we started with the systematic review. The next part of this is really going to be putting together a Delphi group, and we're in the process of doing that at the SRS to really understand what those differences are and what are the best practice areas. Here's what we know today, right? These are our methods for this analysis. We looked at TL patients. We looked at those that had implementation of ERAS protocol, and we looked at comparison between pre-ERAS and post-ERAS in these four areas: medical complication rate, 90-day readmission rate, opioid use, and length of stay. There were 62 articles that were part of this. We included 8 of these studies, and the commonalities for those of you that know ERAS are preoperative optimization, intraoperative stress minimization, and postoperative recovery facilitation. This was all in the original Seattle approach from 15 years ago. That was the first analysis to really talk about doing this in adult deformity patients. But now it's codified a lot better. And what we look here is on these studies, right? We see this trend toward improvements in this post-ERAS group in length of stay, medical complications, 90-day readmission rate, and total opioid consumption, MEDs. The length of stay discussion deserves a little bit of a side discussion here, right? 4 studies showed a significant reduction in length of stay. 2 studies actually revealed an increase in length of stay. And so that's really not perfect here. I mean, it's clearly controversial. While the result was there, the observed difference, it was only nearly significant. So there's some disagreement there. So in agreement, right, postoperative outcomes in terms of medical complication rates, 90-day readmission rates, and opioid consumption, that's what we found in the original Seattle approach. That's what we originally published. And so that was really your first ERAS of adult deformity patients. This length of stay, again, it's controversial for all the reasons I just discussed. What are some of the reasons? This is why we need further work in this area. This is why we need a working group to look at ERAS and adult deformity, because there's a heterogeneity in the primary goals. There's a small sample size and short-term outcomes. What I found also is if I talk to all the major institutions here who do a lot of deformity surgery, there's probably significant variability between St. Louis, Toronto, San Francisco, Los Angeles, right? San Diego. There's just so much variability in how we're all doing this, right? So going forward, we need these working groups. So in conclusion, I think that these protocols for ASD surgery are very important. And the 3 areas that you need to take away are preoperative optimization. You've heard some amazing talks this morning about that, bone, obesity, et cetera. Intraoperative stress minimization, which is really teams, dual surgeon approaches, an anesthesia protocol, things like that. And then postoperative recovery facilitation. The interventions and the primary goals of the ERS protocols varied across the included studies. That's the need for having more work in that area. I think that it clearly shows us, though, that there is reduction in readmission rate, medical complication, and opioid consumption. Length of stay remains to be seen. Different hospital systems may prioritize other factors when designing their ERS protocols. I don't know if that's going to be from the perspective of a Center of Excellence contract. I don't know if it's working within a Teams bundle. Whatever that hospital system wants to do, you may find that you'll prioritize different factors. But we really need a consensus-based Delphi on this area, so that at least when it comes to adult complex spine surgery, we have a better way forward. Thank you.
Thank you, Raj. Questions, Martin?
So that's a phenomenal talk. And I think I've read that book, Team of Teams, which is also a really great book. For some of the fellows or the young faculty in the room, what would you tell them on how to approach their health system, approach anesthesia or the other spine surgeons to get them invested in building a team, right? Is it looking at prior outcomes? Is it setting an agenda? How would you advise them?
Yeah, so I think that's a great question. The question I'll just repeat is how do you teach fellows and young surgeons how to get buy-in from your organizations to build teams? And I think that is an important, very important comment, very important question. What you should do is at the institutions where you're learning, go and learn from those people that can facilitate bridges and those that are able to help others see the perspective of these patients or the perspective of the service line that they're leading, right? A lot of surgeons think that you can walk into an office and just say, I need this and I'm doing a lot of work and I'm bringing you a lot of gravy into your institution, so you got to do it. It doesn't work like that. I think it's really trying to facilitate those perspectives and learning how to speak the language of the people that you're trying to bargain with. And so what I mean by that is there's a financial equation in almost every scenario here, right? And so if you can show that you're reducing length of stay and you're able to tabulate what that means to the organization, you can speak the administrator language to maybe get a part of that team established, right? If it's throughput in the operating room, we want to do more cases, right? So therefore, this is why we want to use a dual attending surgeon protocol, because we want to do these cases faster and do more of them. That can translate into a very good economic equation, right? So learning what those areas are, I think are very key. The second part of my answer to you is really, as surgeons, we really need to grapple with healthcare economics, and we really need more curriculum and more curricula in the medical school phase to teach us about this, particularly as it gets more complex. So focusing on some of those topics, I think, is important. Manish.
You've obviously done a great job in Virginia Mason to convince the administration and getting this done. I think one of the biggest problems is financial explanation and motivation. So if you are a young person, you have no idea how to get that information. So how did you find partners in administration to put dollars and cents to convince the administration, because that's the only language they really speak?
Totally correct, Manish. So just to repeat what Manish is saying, which is filled always with immense levels of truth, is that when you're young and you may not understand the entire value equation, and you may not understand the health economics around all of this work, how do you convince administrators who really only care about the bottom line? And what I would say is, I totally agree with you, you have to speak their language. Right. And so you have to start to understand what things cost, what metrics they're looking at, how they're getting judged, So to answer your question specifically, right, we think about longevity, right? Most of us surgeons, we go to a practice and we stay there for a decade or 2 decades or maybe even longer, maybe our whole career, right? We don't move around every 2 to 3 years. How many of your administrators stay in their positions for more than a year or two, right? Let me ask theologians, like, you've been at UCSF 10 years, right? If you take any of the administrative jobs that you know, or administrators that you deal with, I actually SIG's been there even much longer. You've probably dealt with double-digit administrators, because guess what? They have a different command chain, number one, and their metrics of success are sometimes completely opposite of yours, right? They're short-term deliverables and they're short-term spreadsheets. So you have to somehow bridge that gap, and to think that you're not going to have to speak that language, you will fail. You'll fail miserably, and you'll be very unhappy as a surgeon, particularly if you want to affect major change going forward. So I think it's trying to speak that language, but maintaining your integrity at the same time.
Yeah, thank you, Raj. One thing just to get
back there.
Oh,
Yeah.
Go ahead, Zach.
Yeah, I just had a question. You mentioned in medical school, like increasing the education regarding the policy aspects. And there's a lot more programs nowadays that have like MPH, MHA, MBA. And I was wondering if you thought that is like a good step in terms of increasing your understanding, or if the degrees like aren't necessarily as important.
So Manish and I both went and did executive training very late in our lives. Okay, I was probably the oldest PhD student in the history of this university. I went back much later, you know, close to the age of 50, and did that. Right. Manish went and did an MBA. I think your question is amazing. If you could do that earlier in life, if I had to go back, I asked Manish the same question. Would you have done it earlier? Absolutely. Right? I would have done it earlier too. If I had understood all of this at that time. I just didn't. You know, there's also other pressures, right? You're in debt, you're trying to build a practice, you're trying to raise a young family. There's so many other things that are going on that it's maybe hard to take another degree, you know, when you're in your first 5 years of practice. But I think your question is totally spot on.
Awesome. Thank you so much.
Yeah.
I would add a comment to that. I would say don't do it too early. So don't do it right after your training. I think you have to have 7 to 10 years of some sort of world experience to do the executive MBA to make sense out of it, because you need world examples. So sorry to interrupt, but I think 7 to 10 years is perfect.
Raj, terrific work. And I think what you're putting together here is really key to a value-based healthcare system and the sustainability in spine surgery. One of the things that I didn't see as an outcome, I saw length of stay, I saw complications, 90-day readmissions, but was basically cost of care. Mm-hmm. And now probably length of stay is somewhat a proxy for that, but I think that there are probably other things is to think about the cost over a 90-day period or cost over a 2-year period. So where's the cost effectiveness of these programs?
Yeah, so that's a great question, Sig. The 62 papers that we reviewed for this systematic review, there was almost nothing about cost or cost effectiveness. And as you correctly point out, length of stay was the surrogate in some of the studies. I think we can do better work in that area. And to Martin's question from earlier, how are you going to convince healthcare administrators to do this work? We're going to need to do that actually, to show them that, this is your upfront investment for this team, but down the road, this is what we're going to save, right? And I do think the second part of your question, the second part of that, which is, we've talked about all these interbodies that all of us are putting in, right, at all these levels. I would really give some caution to some of that, because bundling of these surgeries is already here in certain ways, right? So when they're going to pay you X number of dollars for the adult deformity reconstruction, right, based on however many levels you're fusing, right, T10 or T4 or high, whatever, I think that cost effectiveness equation is going to come in too, right? Whereas, Hanjo Kim, my friend at Special Surgery, is doing some pretty amazing work at looking at doing these operations really quickly with an all posterior approach with no interbodies, right? And so Part of that is length of stay. Part of that is cost of implants. Part of that is, patient satisfaction. So I think all of these things are going to get increasingly, measured.
I'll just put it very briefly. I don't know how many people know that UCSF on January 1st, mandatorily, we're going to be included in CMS teams, which is for our Medicare population that's non-HMO. We've got bundles for all of our posterior and front and back fusions, so excluding decompression, excluding cervical, but we're actually mandated to be in bundles for our Medicare population starting January 1st. About 750 hospitals across the country, UCSF's one of them, and that's going to have a big impact on how we think about our cost of care.
To add to that, I highly recommend that all of, particularly young surgeons, have a look at a paper that was published by Jeff Gum on something called the MAR, the Medicare Allowable Reimbursement, about how much money we're losing on every Medicare patient on these long constructs, right? So right now, including at UCSF, your administrators know that if you have a certain uptick in a commercially insured business, right, you can pay for all that Medicare work, right? But as these teams bundles take effect and as they realize that you're losing money on every single patient, you may not care because you're getting compensated by RVU, right? Things are going to change, and so we have to really grapple with this as a community going forward, so that we can maintain access for our patients.
Thanks, Raj. That was great. Maybe you can post that link somewhere we can access it all.
Yeah, absolutely.
All right. Well, thank you, everybody. We are running quite far behind. This is going to be my topic here, tailoring thoracolumbar deformity surgical strategies to the frail. A lot of this has been covered in really great detail, really eloquently so far. So I'm going to, for the sake of time, move through this fairly quickly. But I do want to show how some of these concepts really particularly influence me in my minimally invasive spine practice. These are my disclosures, not really relevant to what I'm talking about today. But again, looking at adult spinal deformity surgery for some of the work done by all you guys out in ISG out there, we know very high complication rates in the 50 to 70% range. But what we also know is, in these complex surgeries, if we get patients through this, there still is in any related outcome measure that you look at, these patients do much, much better in the long term compared to those that don't have surgery. And so associated high complication rates, but still great improvement with these types of operations. This is some of the work done by Chris Ames and John Burke when he was our fellow. First of all, defining the problem. In these complex surgeries, frail patients and the complications they're experiencing, how do we categorize these types of failures? And we wrote a paper about this that you can reference to talk about PJK mechanical failures and those sorts of things. Now, at UCSF, we do, for these frail patients, we do have order sets built into the EMR where you can activate a prehabilitation order set. And so for patients that fall into these categories, there are options if you have the time and the resources to get these patients somewhat more optimized in the preoperative setting but before undergoing a deformity operation. Now, I'm going to talk about some of these concepts by way of history. And first is a relatively straightforward case, is a 78-year-old female, overall very healthy. If you calculate her frailty score, she's in the not frail category. She's had multiple years of back pain, some leg pain, and although intact, she does have a fairly complex deformity where she's sagittally imbalanced, coronal shift, type C curve, and decompensated with an elevated pelvic tilt. She's had an onlay fusion in the past, so solidly fused in this deformed alignment, and does have stenosis explaining her leg pain. And again, autofused both anteriorly and posteriorly at the lumbosacral junction. So this was our plan. What would be our standard plan at UCSF, open T10 to pelvis with an asymmetric L4 PSO, multi-rod construct, cement augmentation of the UIV and the UIV plus 1, and ligamentoplasty. I'm typically using navigation for all these operations and employing the two-surgeon model. So I do all of these cases with Elecos, and we really do believe in this model. Some of the data behind these techniques, Chris has written about multi-rod constructs and decreases in revisions in PJK to a very highly significant level, and we really have moved towards these multi-rod constructs for all our deformity. Mike talked about this earlier. He's really kind of the leading edge of a lot of this research, ligament augmentation to prevent PJK, PJF. And in several of his papers that I'll reference here, using this particular technique, again, to your talk yesterday, you can get significantly decreased rates of PJK, and this holds true through the long term as well in this minimum 1-year follow-up data set with a large group of patients. Now, cement augmentation, this is alluded to a little bit, particularly Chris's and Vedat's technique of more or less fluoro, less vertebroplasty, so adding efficiency and decreased radiation exposure to the patient and the surgeons. And if you look at this, even on multivariate analysis, looking at PJK and PJF, the vertebroplasty at UIV and UIV plus 1 really does stand up to that multivariate analysis, independent predictor of PJK and PJF. This has also been alluded to even just right now with Raj, but we do believe in the two-surgeon model. And Chris and Vedat did publish this. Similar radiographic correction with 1 versus 2 surgeons, but significantly lower blood loss, shorter surgical time, and overall less major complications, less return to OR. And so again, we're applying this strategy to all of our deformity patients. This is what this particular patient looked like during surgery. You can see the deformity, and after the instrumentation, decompression, and ultimately the correction, multi-rod construct. You can see the ligament augmentation and the closure of the PSO. And this is what it looks like intraoperatively. So this is alluded to a little bit yesterday as well for complication avoidance. Intraoperative reconciliation using the O-arm and getting basically a long plate during the operation. You can measure all the things that were really well described yesterday by Mike and others, L4 to S1 lordosis, PILL, and both spinal hip axis measurements as well. These are done at the end of every case and corrected if needed. This is what it looked like, both intraoperative reconciliation, pairing very, very well with what the ultimate construct looked like in the postoperative setting, both sagittally and coronally. Now, this, again, up front, that patient was not frail. Now, Corey gave a really amazing talk this morning on frailty, but just to define it one more time, because it's such an important concept, frailty, it's a medical syndrome with multiple causes and contributors characterized by diminished strength, endurance, and reduced physiologic function that increases an individual's vulnerability for developing increased dependency or death. Basically a measure of physiological reserve and the ability to recover from an insult such as adult spinal deformity surgery. It does increase in prevalence with age. And this is critical because in the general surgical literature, now moving into the spinal surgery literature, it does correlate better. Frailty correlates much, much better than chronological age, the rate of infection, dehiscence, any type of infection, delirium, adverse events, length of stay to what was just discussed, discharge location, and mortality. The frailty index that the ISSG came up with was the first deformity and spine-specific frailty index. The way this was defined is at least 30 to 40 variables. This is how you select a frailty index in any setting. It has to be related to health status. The prevalence increases with age and doesn't saturate early. And it does cover a wide range of systems, in this case, systems that are specifically important to us as spine surgeons. And this is what what it looked like. I borrowed this slide from Chris. I don't know what poor pre-med student had to design this for him. But ultimately, this was how the 30 to 40, or the 40 adult spinal deformity frailty index categories were defined as the overlap of multiple pre-existing frailty indices and figuring out which one of those were specifically relevant for spine surgery. And as Corey mentioned, this was published in Neurosurgery Focus, and frailty, particularly when codifying it into different severities of frailty, does predict complications. And the importance, and this will ultimately get into how we're tailoring these strategies to the frail patients, but a frailty index does really need to be paired with an invasiveness score if you're looking to predict outcomes based upon frailty. And so the ISSG also worked on an invasiveness score based on their data set. And ultimately, when figuring out if the invasive score works or not, it has to be correlated with things that you would think of with invasiveness of surgery being increased blood loss, increased length of surgery, and then comparing that to some existing invasiveness scores like MIRSA. It did actually really pan out extremely well as far as being able to describe the surgical invasiveness of our operations. So in thinking of that with the background and under the mentorship of Chris, I was really interested in how this applied to minimally invasive spine surgery. And so we worked on this paper, again, John Burke, when he was our fellow, comparing open and MIS TLIF patients in both the frail and the non-frail categories. And what we found when looking at different outcome measures, the two that really panned out were discharge location other than home and revision surgery at 2 years. And what we found is that frail patients, if they underwent an open TLIF, they had the frail patients did significantly worse in these two metrics compared to the non-frail patients. But if these patients were treated minimally invasively, it kind of leveled the playing field. So frail patient did just as well after this as, they did the same after minimally invasive TLIF with irregardless of whether they're frail or not, indicating that may be an important application of minimally invasive spine surgery, particularly when treating frail patients. And so thinking about ways to apply this to the spinal deformity population was, to me, the next thing that made sense. And I love that we have Martin coming up to talk next, and we had a great talk by Coy yesterday about this. But just how we think about this in this, again, a case here, an 82-year-old male, multiple medical problems. He falls into the severely frail category. He has severe mechanical back pain, normal exam, and he does have both sagittal imbalance as well as coronal deformity. Multiple levels of stenosis contributing to his leg pain. And this is ultimately how we came up with our plan. So trying to apply as many of those principles that I discussed early from open surgery to a minimally invasive surgical strategy. Again, 2-surgeon model. So Alekos and I discuss all these cases and we do them together. Started with a stage 1 L2 to S1 OLIF. At L5-S1, a patient-specific ALIF cage, left lateral approach with the vascular surgeon using navigation. And then as a planned second stage, I'll show you some of the imaging. I get the thin cut CT in between stages, which helps with robotic pre-planning and custom rod designs. T10 to pelvis, minimally invasive fusion with some minimally invasive tubular decompressions to treat the radiculopathy, robotic screw planning and placement, patient-specific rods, and this is done through a midline incision, muscle-sparing screw and rod placement. I was lucky enough about a year and a half ago to spend some time in San Diego with Martin and learn that technique that's been really beneficial for me. Some benefits to doing it in frail and obese patients and operating on them in the lateral position. You can see the abdominal contents migrate forward. This is a technique for the L5-S1 lateral ALIF in the lateral position. Incision planning anterior to the ASIS. and in planning your incision between this triangle that's described by these vertical lines. Ultimately, this does have some benefits. It's muscle splitting, possible less hernia, possible less pseudohernia, wide exposure to the disc space with less peritoneal retraction, so perhaps minimizing ileus. And this is what the 5-1 custom implant looks like. So being able to take into consideration end plate anatomy, particularly in patients that may have bone density issues, as well as being able to target both foraminal height reconstruction and lordotic targets. And to some of the questions that have come earlier, there has been some research that's been done based on this. Chris has been involved in a lot of this. But looking at ability to treat successfully your target focal lordosis using patient-specific implants, whether it's ALIF, lateral, or TLIF, and this can be done with very, very high reproducibility. And this can be also translated more globally, looking at realigning and improving upon spinal pelvic mismatch using patient-specific inner bodies that can help you achieve these goals. And this is the third paper that was published upon this from the same group. This is what it looks like with that reconstruction. We've seen cases like this before. I do think it's important to get this CT scan in between. It helps with robot registration and planning. It does streamline that second stage and getting standing x-rays to see how close you've come. With custom rods, we can plan our corrections, we can plan our screws using robotics and that preoperative CT scan to facilitate correction and rod placement. And this can all be done before the surgery starts. This was kind of hot off the press, but we've looked at our series of patient-specific rods. Similar theme here when we looked at our series at UCSF, there was a significant decrease in rod-related mechanical complications when we use these custom rods. This is what it looks like. I'm working with Tony Makula, my past fellow from Mayo Clinic, and then doing the components of the case with Elecos, you can see there. And similar concepts, intraoperative reconciliation, making sure that we hit our targets. And, potentially, these are costly surgeries, but we may be getting some cost savings on the back end. No ICU stay for this patient, no blood transfusions, went to rehab post-op day 7. And by 6 weeks, it's off all narcotics and it's feeling better. So these are how I'm thinking about frail patients. I am going to rely or try to, if I can, to use some form of minimally invasive technique for these based on some of our work on frailty. Thank you very much. All right, I think, guys, let's get some coffee and, we'll, just in the sake of time, we'll go straight into cases. And then we'll get done in time for lunch.